I now call upon Dr. Sharifa Talha, our convener, to welcome the gathering.
Good afternoon. A warm welcome to everyone. The Chennai chapter of the Nutrition Society of India have organized 2 days digital conference on advances and challenges in maternal and infant nutrition to reach a global audience in the hope that it will open a window on the problem of undernutrition and its implication in the very early stages of life. Undernutrition does not fit the narrow definition of a lack of food. Rather, it is a hidden hunger manifested when the diet fails to provide vital nutrients. Therefore, while a severely wasted child may represent malnutrition, equally an obese infant may be malnourished. Worldwide, it is acknowledged that infant and child is linked to maternal nutrition. An undernourished woman is likely to give birth to a low birth weight baby, setting in motion a vicious cycle that can only be disrupted by interventions that improve the nutrition of the mother before conception, during pregnancy, and while she nurses the child. Good nutrition for the infant is also crucial during the first 2 years of life. Fortunately for us in India, the promotion of maternal and child health is one of the most important objectives of the family welfare program of both central and state government. The COVID-19 pandemic has heightened the problems of vulnerable groups like pregnant and lactating mother and infants. Their health and nutritional status has worsened. In the less developed nations of the world, poverty, ignorance, poor hygiene and sanitation, high burden of infectious disease, food insecurity, and lack of appropriate feeding practices for infants and young children stand in the way of improving infant and maternal nutrition. These challenges have assumed a new dimension with the pandemic bringing in its wake of the loss of jobs and livelihood and the escalation prices of food. Given the current global conditions, this virtual conference on advances and challenges in maternal and infant nutrition is extremely timely. National and international speakers with rich experience and expertise in the field of maternal and infant nutrition have graciously accepted our invitation to share their knowledge and present their views. It gives me great pleasure to welcome Dr. Dinesh Kumar, Vice President, Nutrition Society of India, Dr. A. Lakshmaya, Secretary, Dr. Soumya Swaminathan, Chief Scientist, World Health Organization, Dr. S. Vijaya, Director and Professor, IOG Government Hospital for Women and Children. I also extend a very warm welcome to Dr. Chitranjan Yajnik, Director, Diabetes Unit, KEM Hospital, Pune, and Dr. Usha Ramakrishnan, Chair and Professor of Global Health, Rollins School of Public Health, Emory University, USC. To all the other dignitaries, our friends from the media, delegates, NGO members, faculty, research scholars, and students, a hearty welcome as well. I hope you will find this international conference a rewarding and enlightening experience. Thank you. I welcome you all once again.
Thank you, ma'am. To deliver our presidential address, we have with us Dr. B. Dinesh Kumar, Vice President, Nutrition Society of India. I now call upon Dr. Suganti to introduce the speaker.
Good afternoon. I'm very happy to introduce Dr. B. Dinesh Kumar, Scientist G, Coordinator, Center for Advanced Research for Preclinical Toxicology and HOD, Drug Safety Division, and NIN Animal Facility Counselor. He is a National President, Indian Pharmacological Society, Vice President, Nutrition Society of India, and former National Secretary, Nutrition Society of India. He is a scientist with pharmacology background, and he has contributed to ICMR NIN to break new grounds in the area of nutritional pharmacology and toxicology. He has established state-of-the-art facility center for advanced research for preclinical toxicology. He has completed the safety of innovative products, successfully implemented public-private partnership, and strengthened the regulatory guidelines in India. He has coordinated several projects with IEA, WHO, World Bank, and CSIR, ICMR, etc. He has developed several models for non-clinical efficacy evaluation of various products. Exclusive research work he has done in new area of nutrition pollution interaction and generated data for assessment of leg toxicity in target population. He has contributed in the areas of social drug epidemiology and developed the innovative intervention program in promotion of rational drug use. He is a recipient of Normal Borlaug Fellow USDA, Counselor, Pharmacology of Natural Product Section. He is a WHO Fellow in Action Program on Promotion of Rational Drug Use. He is an Indian participant in OECD meeting on biosafety and novel food and feed safety on nomination by Ministry of Environment, Forest and Climate Change, expert member in various organizations like FSSAI, Ayush, DBT, DST, etc. He is a fellow of National Academy of Medical Science, fellow of Andhra Pradesh Academy of Sciences, fellow of Telangana Academy of Sciences, fellow of Indian Pharmacological Society. He has got Young Scientist Award, Andhra Pradesh Academy of Science, from Nutrition Society of India, Indian Pharmacological Society, and delivered CDRI oration and and B.N. Das oration. He has more than 75 scientific publications with an average impact factor of 2.6. We are indeed very happy to have you, sir, and over to you, sir. Over to you, sir, for delivering the presidential
you
address.
are muted. Can you please unmute?
Now you can unmute. Yeah, please.
Yeah.
Can I have the slide presentation straight away, madam? First of all, I'm thankful to the organizers. First, to my president, Dr. Hemlata, who was otherwise busy with her other assignments. So they have given me this opportunity. Dr. Lakshya is also here. I take this opportunity to first introduce to you about the Nutrition Society of India. Can I focus the first slide, madam? Can you focus my first slide?
Yes, sir. Done, sir.
In a presentation mode.
You have to because I am in mobile.
It shows side by side. You click on the resume slideshow, madam, so it will work.
This meeting is being recorded.
Sir, can you see the slides, sir?
Yeah, we are seeing all the slides, madam. Can you go to the slide number 1?
It is a starter mode, but the presentation mode, make it presentation mode, please. The slides are in starter mode. Dr. Dinesh, did you share the slides to them?
Yes, sir. Yes, sir.
I have already shared the
Yes, I have
slides.
changed it.
It is
It's
not coming.
It's
Not
not
coming.
reflecting here, Menaka. It's still in the slides sorter. So
Starter mode only.
maybe you should just press that resume presentation, and I think you will be able to get it.
You please come to the cup, madam.
No, here you can see the 3 symbols are there. You can, this last dumbbell symbol you can press. No. It's coming again, same.
Manaka, madam, you see that, yeah. Click
Madam,
on that
you are able
up
to
symbol.
resume the slideshow. Come to the resume slideshow. Come to the slideshow.
Here in the down, there is a dumbbell symbol is there. You click on that.
Sir, changed it.
No, not coming.
Ma'am, you have changed, but you are shared the only all the slides. You can see on your screen on the right side, down below, you can see one cup symbol. Next to 100%, you just click on that. Now click resume slideshow. There is a icon. We just come click on that.
Is the slides moving, sir?
No, madam, you have to double click that.
Yes, I've done it, sir. The network is not.
No, madam, Please, madam, we have attended so many Zooms. We are getting really confused because people are not connecting it properly. Please ask your person who is operating there.
Who is there in the technical person? Hello, you just double click on the first slide. Or you go down and click on the dumbbell shape. Now you
can
dumbbell
go to
shape.
the slide
Yeah,
view.
dumbbell.
Very good. Click it. No problem.
Next slide, sir. Next slide.
Yeah, you can click it.
Dumbbell shape, the cup shape you click.
You have already taken the.
Can you see the second
system.
slide, sir?
Can you take my input, Manaka ma'am? Just stop sharing.
Yes, sir.
Okay, just put the first PPT full screen first. Then use the Alt tab and come to the Zoom page. Click the share screen and use that full screen. Screen second will come. Click on that and share it, so you'll get the full screen.
Otherwise, you can. Madam, you can mail. You can send mail to somebody.
Yeah. Yes.
Now click that full screen option. Yeah.
Dr. Dinesh.
Yeah, please. I'm going ahead with this, sir.
This is enough. You go ahead. You go ahead. Okay. Hello.
Madam, we have completed more than 50 years of the existence of a Nutrition Society of India. It is important to recall the name of Professor Gopalan, who has started this society with a vision that the nutrition is the important subject in the both medical, social, and economic fronts. And today we have more than 5,000 members on board on the Nutrition Society of India. You are aware that our 50 years Golden Jubilee celebrations, we have selected a theme that is India's transition from food security to nutrition security. Now, this is coming true as the time is passing, and organizing secretary has already mentioned that this is one of the important global topics. So we are going ahead with this topic, and I compliment you, the Chennai branch, for organizing such a symposium and a conference so that it can go and messages will be communicated through this program. Next slide, please. And in the COVID operations also, next slide. Go to the next slide, please.
Yes.
Madam, somebody should be attentive, madam. Otherwise, what happens is this will not. No, it is not correct. There is no technical person, madam? Why are you paying the money to this Zoom person who is helping you? What is he doing?
Sir, can you see the second slide, sir?
Given you a link, he should
No, not yet coming.
also.
Second slide not yet come. You can press simply down.
Who is your person, madam? Don't give your service charges to him. If he has
the
given you
slides
such
are
a link,
moving
then don't
actually
give your service charges.
Can you ask that other person?
Yes, ma'am. Yes, ma'am. I'll do that, ma'am.
Yeah, let him present it. Yeah.
Otherwise, you can mail to me. All slides you can mail to me.
Lakshmanayan చేస్తున్నా ఆగు.
Say.
Lakshmanayan చేస్తున్నా. లక్ష్మయ్య పంపుతున్నా చూసుకుంటా.
పంపినా
Hello. Hello.
Sir, if you present, it will be easy, sir.
I cannot say because what happened is the person who has given you a link, he has not given. That is why I requested you should have taken NSI link. We would have easily done. The person who has charged you, he is not giving a proper link. He doesn't know how to give.
Excuse me, ma'am. Ma'am, can I try
Studio,
sharing the
this studio-
screen, ma'am? I have the presentation with me.
Yes,
Yeah,
Lakshya.
sir.
Yes, yes, please.
Yes, ma'am. Just give me 1 minute. Ma'am, are you able to see my screen, ma'am?
Yeah, but it's in the sorter mode. So
Yes, ma'am. Yes, ma'am. Just give me 1
I'll
minute.
share the screen, okay?
Ma'am,
Can
are you
check?
able to see my screen now, ma'am?
yes, 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 yes.
Okay, ma'am. Sir, if you can ask me to change the slides, I'll do so, sir.
Yeah, now please go ahead with the next slide, madam.
Yes, sir.
Next slide. Next slide. Yeah, now we have celebrated the Golden Jubilee, and in fact, in the COVID also. Go back, madam. You are very fast. Go back. Go back. Yeah, during the COVID also, we have conducted many symposium online, and we have also conducted the Gopal oration. Next slide. Gopala oration, Rajmal Devdas oration, and Srikanta oration. Now, most likely this year, the physical meeting will be held. Dr. Lakshmaya and our team is going to announce you soon. We are going to mention where the venue and all those things. Dr. Lakshmaya is the secretary, sir. They also should be provided with the link. This is what a request come from the organizer. Next slide, please.
And Dr. Dinesh, Rajmal they have got already advertised, but we have already sent communication and no one has sent the nominations. So in this regard, please.
Okay. So I think, sir, it is a. Please take a record of it, madam, and try to request members to submit the Rajmal Devdas. These are our objective. Next slide, please. Because I want to skip because of the time, madam. Next slide. Whoever is operating, this is our executive committee, which is all on a website. Next slide. Yeah, actually I have been asked to give presidential address. Your topic of selection is that advances, challenges in the maternal and infant nutrition. Next slide. Next slide, please. Yes, I'll go back, madam. Don't be so in a hurry. Don't be in a hurry. Go back.
Okay, sir.
Right, madam. Please stay there. Now you are able to see the cartoon is very clear. Modern diseases of, madam, I think somebody is playing a mischief here.
Yeah, I think so.
Next slide.
Yes, sir.
Madam, only one person let be operating, madam. Otherwise, what happens is I am also not getting an interest to now speak much.
Please.
Modern disease of civilization may be due to ignoring our recent evolutionary past, but it was not perfect then. If you see, the modern nutrition science has started from the 18th century. It can be regarded from the citrus fruit which has been given during the Noble time. And the chemistry has made a revolution, and this revolution has actually led to the biochemistry, molecular biology, and new sciences are now emerging. Next slide. Next slide, please. Now you can understand from this slide what are the factors which are making effect on the child health and the nutrition, from the lifestyle disorder to the food habits and other physical, psychological, and other factors are playing an important role which are making an impact on the maternal and child health. Next slide. Now I am just presenting this slide for a minute because where you can just see the concept of triple burden has come, but in this double burden you must understand what is an undernutrition per se and what is an overnutrition per se. Both the things have been separated. If the mother is, if the pregnant woman is not fed properly, the cycle will be down. And here you can just see a lot of undernutrition per se, which we will be affecting the child growth. And if you are going and not having the proper overfood or over the without exercise and lifestyle disorder, it leads to the diabetes and obesity, which has become a very serious matter nowadays. So now it has been considered as a triple burden. Next slide. I am just planning to put this slide in front of you. After the double burden and the triple burden of the diseases, the new burden has come. The people say after the COVID, there will be a new world which is closed for renovation. Now is going to have the grand reopening, and we will be definitely having the new challenges in front of you apart from these three. And we have to take this as a first lesson after the COVID disorder which has been existing now. Next slide. Whether Darwin is correct or wrong, that we have to really think why you are linking a Darwin. This is the statement you will be asking. Darwin has very clearly said that it is not the strongest of the species that survives, nor the intelligent that survive. It is one that is most adaptable to the change. Now we have to work it in such a way that most adaptable change we have to bring. This is what the Darwin is correct in his aspect. Now that is what exactly we are now adapting to the systems which were traditionally there in the post-COVID era. Next slide. One important Sanskrit slok where you can just see a person cannot sustain life without ahar. That is a diet. If endowed with in spite of endowed with the medicine, that is the reason that ancient scientists praised that ahar by giving it a synonym, maha, bhashya, jaha. That means a super medicine is the ahar. This is what has been written in our traditional text. So food is and diet is the important aspect which is written from the long history and which we have to follow. Even the Hippocrates has said food is a medicine, medicine is a food. Next slide. I am just putting to the new insights of the 21st century. In this 21st century, unpacking the triple burden of the children which are nutritionally well-being. Like State of World Children, SOWC, is now extended the target of 2025 to 2030. And the children who suffer food and nutrition growing well in the changing world is the concept in which you can just see underweight. I have written underweight, hidden hunger. Hidden hunger where the children suffer from the deficiency of micronutrient and the overweight. These are the triple burden factors which have been described by the UNICEF, and it has been defined that we have to address and we have to really speaking unpack these factors so that our child nutritional program which has been there in the 21st century can be successfully implemented. Next slide. You can just see here that there are the 6 factors: stunting, growth, anemia. Then this extension is given based on these 6 factors which are been mentioned here. And this is the WHO Assembly which has met in May 2012. And all these 6 factors are still matter for discussion. And some of them have been addressed by the intervention strategies. Next slide. You can just see antenatal multiple micronutrient supplementation has definitely reduced the stillbirth, low birth weight, and babies born at a small gestational age. Then coming to the supplementary food in a food insecure settings, that is a community-based approach where indigenous or locally produced supplementary and therapeutic food to manage the children is one of the aspects which also has been become a successful intervention. Some emerging interventions such as preventive of a small quantity of lipid-based nutrient supplementation for the children of 6 to 23 years has also 23 months also has been focused and has been proved to have some intervention benefit. Then coming to the management of a childhood obesity and integrity intervention, exercise, behavioral changes, and diet control can definitely modify the whole the third burden, that is obesity in the children. There are some indirect nutritional strategies such as malaria prevention, pre-consumption care, water, sanitation, and hygiene, which are really known to promote and deliver inside and outside the healthcare sector. And these sectors are again depending on the interstate, family or inter area, which are important to maintain these type of factors, so that these successful interventions can be adopted throughout the globe. And then we can just see the good results out of this. Next slide. This is the RAS. You are able to see that the government of India has one beautiful program, and our current director, Dr. Hemalata, has done extraordinary work in this 1,000-day concept. You are aware of it, about it. The lot of concentration has been given, and this has been mentioned very clearly by Dr. Hemalata. Next slide. Next slide, please. And why 1,000 days are important? The concepts have been very clear that 1,000 days from the day of planning from the pregnancy till the 2 years of celebration, you have to see that. Now, the UNICEF also has given a very good 10 commandments, and these 10 commandments you can just see around, so that it can be, because I am not able to focus you because of the lack of time, but I would have definitely touched upon each of the aspects. And these slides are available. The organizers can definitely share with all the participants. Next slide. The lifestyle, when we have mentioned very clearly, this is the lifestyle currently is having, and this lifestyle disorder has to be changed. When there is a GO, nobody in the family members are talking, are able to do any exercise. There is no mental exercise, physical exercise, or any of the exercises. Next slide. Next slide. Now, you may be aware that NIN has completed more than 104 years, and our great achievements are on immunity and how the micronutrients play a synergistic role in supporting the immunity. And for this, we, in the COVID operations and in the COVID, this thing also, our micronutrient supplementation has been given. The government of India has rendered our gigantic efforts to keep the India hunger-free and health by providing the stable foods and incentive for the low-income families and migrants. And next slide, please. Next slide, please. Our 1,000-day, hello. We strongly advocate our plate meal, which we are in front of, it is there. We want to advocate this concept among all the families in India. You can just select your local food and you can have this plate, which will be full of nutritional requirements from the all point of view. Next slide. Next slide, please. Now, there are some strategic interventions which the whole world is looking after it, that world needs a step to efforts in eliminate malnutrition in all forms and break the intergenerational cycles of poverty. More sector beyond the health and agriculture, and more actors need to be involved. When the last line is very important, the multi-sectorial approach calls for a collaborative work to develop a strategic need that will involve poverty reduction, education, women protection, improvement in maternal and child health to reduce the burden of diseases on the child. Next slide. Next slide. This is what actually whether our government is going in a direction. Yes, we have selected the 5 pillars, and these 5 pillars, if they are implemented in a total manner, there may be a collaboration which can make us achieve to go to this goal. Next slide. Please let us just come to the modern concepts rather than depending on a stone searching by the crowd to get the water. Let us select a straw so that we can upgrade our skill and go in a rapid mode to attain these points. Next slide. Nutrition before, during, and after pregnancy. Eating during pregnancy is not a simply to satisfy your hunger, but also to satisfy the special needs of your body. Ensure that your plate includes foods that the baby requires for optimal development. Give your baby a healthy start in life. This is the slogan given by the Government of India and the Ministry of Health and Family Welfare. Next slide. Next slide. I am a pharmacologist. My ignorance may be tolerated because I have done a lot of work in a pharmacology. My nutritional science is that not strong. But being a pharmacologist, I still believe that natural sources of food which are economically viable better rather than the pharmacy, because health cannot be built at a pharmacy. This is the slogan given by me and Dr. Kamla Krishna Swami, who is also residing in Chennai, our former president of Nutrition Society of India. Thanks a lot for opportunity. I wish you for the good seminar and hope you will be continuing with the future activities for this one. Thank you very much.
Thank you, Dr. Dinesh Kumar. It was very good, and you have thrown light on why food is important. I think even in ancient times, we stressed upon food, and even in the modern times, how diet plays a major role in leading a healthier lifestyle. Thank you so much for giving us your time. Our keynote speaker for today is Dr. S. Vijaya, Director and Professor, IOG Government Hospital for Women and Children, Egmore, Chennai. I now request Ms. Lakshmi to introduce our speaker.
Ma'am, am I audible, ma'am?
Yes, Lakshmi.
It gives me immense pleasure to introduce to all of you a versatile person, Dr. Vijaya, Director, Institute of Obstetrics and Gynecology, Madras Medical College. She is a member of Board of Studies for both undergraduation and post-graduation, Tamil Nadu, Dr. MGR Medical University. Dr. Vijaya is also a proficient examiner across various colleges in Tamil Nadu, Kerala, and Karnataka at both undergraduate and postgraduate levels. Her areas of interest includes high-risk pregnancy, laparoscopic surgeries, and infertility. Dr. Vijaya has published articles in various reputed international and national journals. Madam has received the Best Paper Award in the All India Congress of Obstetrics and Gynecology 2015. She is a national level master trainer in skill lab and in safe delivery practices. Dr. Vijaya is also a state level master trainer in emergency obstetrics and neonatal care, cervical cancer screening and colposcopy, and for non-communicable diseases as well. One of her commendable works during recent times was the tireless efforts that ma'am has put into managing more than 750 COVID-positive pregnant women, for which she has been appreciated by the Honorable Health Minister of Tamil Nadu. We deem it an honor to have such an inspiring personality amidst us. Thank you for joining us, ma'am. I request you to take over the session.
Yeah. Hi everyone, good evening, and it is my great pleasure to be delivering this topic, which is the need of the hour, reducing the maternal mortality and neonatal mortality. It is very, very important that everyone should strive and achieve the goal. I will share my screen and I'll start my topic. And I would like to thank the organizers for giving me a wonderful opportunity. Is my screen visible?
Yes.
Hello?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah. Am I audible clearly?
Very clear, ma'am. Very clear.
Okay. Yeah. I bring greetings from my prestigious Madras Medical College and the Institute of Obstetrics and Gynecology, which is 177 years old and one of the premier in Southeast Asia. And we cater to around 18,000 deliveries per annum. And of course, the ultimate goal is to reduce the maternal death and the infant death. The happiness lies when a mother takes home a healthy baby. That is what we are aiming at always. So to talk about the maternal death, you all know, whenever there is a death of woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration or site, and any cause related to aggravated by pregnancy or its management. But it is not from accidental or incidental causes. It's mainly related to delivery in and around the events of delivery. So when you look at the global scenario, it was 451,000 in the year 2000, and then it has drastically reduced. You can see from the bar diagram, from 385, it has reduced to 211. And now the recent 2020 maternal mortality rate is 152 per 1 lakh live births. And definitely there is a declining trend, and it is slowly declining. But for COVID, because the last year maternal mortality was little high because mainly due to COVID deaths. And we are very, very happy. Our Tamil Nadu has lowest maternal mortality, of course, next to Kerala, and we are 57 per 1 lakh live births. And the percentage decline of maternal mortality is 7.3% less than that of the previous year. When you see the graph, you can see we are comparing India and Tamil Nadu. Tamil Nadu is far lower in maternal mortality. We all should be very, very happy and appreciate ourselves for striving towards the goal. And the trends is from 1994 to 2021, you all see there is a slowly declining graph, and it has come to almost 53.4, and there is an increase to 73 because of the COVID deaths last year.
Ma'am, your excuse me, ma'am, your slides are not moving.
Not moving, huh?
Yeah.
Oh, it's not moving.
No, ma'am.
Okay, 1 second. 1 second. Slide show the beginning slide show. Is it moving now?
You're on the 6th slide, I think.
No, I'm on the 6th slide. I just want to show. Is it moving?
I just came to the 6th slide, ma'am. You're just focused there. We don't know if it's moving.
What slide it is on?
Again, we are not getting your full screen presentation. We are getting only the slide sort of.
No, it is. I think it is still minimized. Can you put it on slideshow and also full screen?
1 second.
Yeah, it's not in the slideshow.
We'll stop sharing.
Ma'am, if there is a problem, can you share the slide? We'll give it to the technical person.
Yeah. We'll do it. Just 1 second, I'll try. If it is not coming out, I'll share the slides.
Okay, thank you.
Haridhar, நீங்க வந்து பாருங்க, இந்த ஸ்லைட் ஷேர் பண்ணி கொடு.
Now you put the slides into full screen mode now.
Yeah, I put. Is it visible?
Normal.
It is like, it's still not full screen, ma'am.
So to whom should I share my presentation?
Lakshmi, can you just...
Technical sir? Ma'am, you can share it to me, ma'am.
Can you mail me?
Give your mail.
Yeah, I'll put the mail ID into the chat box.
Please send it to that mail ID in the chat box.
Dr. Sharifa,
Yes.
you can continue. This is visible enough.
Okay, you can just, doctor, you can continue, doctor, without I mean.
You can continue. Unnecessary time waste. It is visible.
Yeah, it's it. So the mortality ratio, the trends in Tamil Nadu has come down and it has increased to 73% because of COVID. And you all know the preventable causes of maternal mortality is anemia, hypertensive disorders, postpartum hemorrhage, and thromboembolism. These are the indirect causes are anemia and cardiac disease, but the direct causes hypertensive disorders, hemorrhage, sepsis, and obstetrical labor. And the major causes of maternal mortality can be prevented, especially the hemorrhage, by following the active management of third stage of the labor, oxytocin and misoprostol and blood transfusion. Whereas the sepsis can be prevented by antibiotics and 6 cleans: clean hands, clean perineum, clean delivery surface, clean cord cutting and clean cord tying, and clean cord care. And hypertensive disorders, you all know, magnesium sulfate plays a very important role, and labor problems can be prevented by the proper usage of portogram and by going into labor or a cesarean section or normal delivery. The decision at the correct time is very, very important. So coming to the timing of the maternal death, most of the maternal deaths occurs in the intra and the postpartum period. And gravida is, when you say, it is really surprising. It is not the higher order birth that has the maternal death. It's only the primary, and the gravida too has the highest number of maternal death, both in 2020 and 2021. The place of death, you all know the Medical College Hospital has the highest number of maternal death because of the late referral. And age-wise, when you see, it's around 20 to 30 years, the most maternal deaths occur. And you have to prevent all these problems. If anemia management, you all know it needs to be a pre-pregnancy counseling and iron-rich foods and widespread use of iron sucrose injection and ferric carboxymaltose and blood transfusion services for severe anemia. And pre-eclampsia, you all know, proper recording and monitoring of the blood pressure and giving magnesium sulfate in all cases of severe pre-eclampsia, imminent eclampsia, and also when you are transferring the patient, give magnesium sulfate and then transfer the patient. You should all know about the imminent symptoms of headache, blurring of vision, and epigastric pain. And you all know about the magnesium sulfate. We usually follow the Pritchett regimen, and of course in our institute we follow the suspense regimen, where you give magnesium sulfate totally by IV 1 gram per hour through an infusion pump. An antihypertensive, you all know, labetalol plays a major role in prevention of preeclampsia and eclampsia. And PPH, the next third important one, which causes 24% of maternal mortality, and PPH should be prevented by birth complication readiness. And skilled birth attendant is very, very important, and early identification of prolonged and obstructed labor by partogram, and avoiding unnecessary augmentation and fundal pressure, controlled head delivery, and active management of third stage, and checking the completeness of the placenta after delivery. You all the hospitals should have a PPH management tray and kit readily available, and you should also have a condom tamponade. And so whenever there is a PPH, you all know you have to have a proper health personnel, and 2 established lifeline is very important, and blood should be ready, and oxytocin should be immediately used. And if the placenta is retained, we have to manually remove the placenta. And also we can massage the uterus. And one second. அந்த இடத்துக்கு போயிடுறதுல ஷேர் பண்றாங்களா? Okay, they are sharing. Please share the 26th slide.
26. Okay.
Yeah, because I have come to 26th slide. I think next slide சொல்லிக்கலாம். Yeah. So the PPH, we have to massage the uterus and examine the placenta for completeness of the membranes, and if the uterus is contracted, traumatic PPH should be flat. We have to look for trauma in and around the uterus. Next slide, please. Next slide. Yeah. So this is the algorithm for PPH, A20 PPH. Whenever it is not contracted, we have to give oxytocin. We can try carboprost. We can even try rectal misoprostol. And if it is not controlled, then we have to think of a bimanual compression and condom tamponade. Next slide. Next slide. So this is the bimanual compression of the uterus. Immediately empty the bladder. Empty the bladder with pulleys, and then insert the gloved finger into the vagina. Another hand on the abdomen. Do a bimanual compression. Next slide. So condom tamponade is very, very important. All the labor units must have a pulleys catheter with the condom tied to the one end using a sterile tie. And the next one is the surgical management, the uterine artery ligation. The next one. Yeah, next slide. Uterine artery ligation. And the next slide. Next is a thromboembolism. That is the 4th major cause of maternal mortality. You should identify the risk factors for thromboembolism, mainly immobilization, and so any surgery, even cesarean section, and also obesity. Pregnancy itself is a cause of hypercoagulability. So we should have a prophylactic anticoagulants, early mobilization, and compression stockings is a must, and adequate hydration, because we've seen so many people discharged, healthy mother coming back with fits because of dehydration and cerebrovascular thrombosis. Next slide. So antenatal assessment, you have to identify the risk factors, and then you have to strategically classify whether they are intermediate risk, low risk or high risk. Based on that, you should decide about the using low molecular weight heparin. Next slide. Next slide. Yeah, so prevent thromboembolism, early mobilization and adequate hydration. Next slide. So various innovations have been on to reduce the maternal mortality. We have to have a death audit meeting, community-based maternal death reviews, or facility-based maternal death review, and near-miss audit. These three are very, very important in reducing the maternal mortality. And also we have to enhance the skill hat providers in the rural areas and increasing the availability of specialists in the first referral unit. And also blood and blood components are very, very important. We should have a 24 hours blood bank in all the facilities. Next slide. So these are the maternal mortality preventing factors. Coming to the neonatal mortality and preventive measures. Next slide. You all know neonatal death is occurring within 28 days of age. Next slide. So mainly it is due to the death within 1 month is very, very high, 68.5%. And early neonatal death, male are more common than female, but late neonatal death, the female children, late neonatal death is more common than male child. Next slide. So the neonatal mortality is mainly due to low birth weight, prematurity, and also sepsis. And prematurity forms a major part. Now that the IVF conception has come, it's because of we tend to deliver by 34 to 35 weeks the borderline preterm infants, and also because of IUGR and malnutrition, low birth weight babies forms a major chunk of neonatal mortality. So this is the cause of mainly birth asphyxia and preterm. We have to prevent birth asphyxia, and how are you going to prevent the birth asphyxia will be coming in the next. Next. Next slide, please. Yeah. So when you say compare the rural and urban, previous slide.
Sure.
When you compare the rural and urban maternal neonatal mortality, you can all see in the rural the neonatal mortality is high because of the lack of infrastructure facility and lack of HR, human resources. Next. So what we can do, you have to start from adolescent, reproductive health, we have to delay the age of marriage, and we have to give proper nutrition, counseling, and antenatally we have to screen anemia and hypertensive disorders, and malaria, and prevention of anemia, and always contraception, interval IUCD insertion. Now we are having postpartum IUCD insertion, so we have to do family planning procedures, and RH anti-immunoglobulin is a must. Main thing is hypertensive, diabetes, and anemia. We have to screen and find out. Next. So during labor and childbirth, skilled birth attendant, this is a very important concept, clean birth practices, and allowing at a birth care attendant to be with the patient. Earlier, we never allowed anyone to be with the laboring mother. Now we are allowing the relative, close relative to be with the mother throughout labor. And antenatal corticosteroids forms an important role in preventing preterm labor and respiratory distress of the newborn. And also for PROM, we have to give antibiotics, and magnesium sulfate is also given for prevention of neurological complication in preterm infants. Next. So for family and community, not only during delivery, up to 6 weeks, and nowadays even up to 1 year, we follow the mother, go at home, the ASHA, trained ASHA are there, and exclusive breastfeeding up to 1 year is a must, and proper immunization plays a major role in preventing the neonatal mortality. Next. So sick and newborn, you have to have integrated ICU, and ANM should be trained to use the Gangaro mother care, and also giving antibiotics and intensive care services, and widespread use of surfactant for the RDS is very, very important. So these are the preventive measures. Next slide. So coming to the last part of the message, very, very important, the Lakshya program for pregnant and newborn, the labor room, quality improvement initiative, which is a need of the hour, like at NABH, all the labor room should be Lakshya National certified. Next. The main components of the Lakshya is to improve the quality of the labor and delivery, and also reduce the neonatal and the maternal mortality rate, and also the beneficiaries should be satisfied at all levels. Next slide. So you should do privacy. You should give birth companion to the mother. Mother can choose any comfortable position during labor, need not lie down, need not be in lithotomy position, and the protocols adherence is must. And we have to use the labor beds. You can labor chair, birthing chair instead of tables. And immediately after delivery, you should delay the cord clamping and you should place the baby on the mother's abdomen and immediately start breastfeeding within 1 hour of birth. And we should avoid unnecessary reinitiation, induction, and augmentation of the labor. You should not verbally or physically abuse any woman, and insist on conventional delivery. You should use conventional labor kits previously, right?
No.
And a lithotomy position should be avoided. And previously, separate the baby from the mother. We should not separate the baby from the mother. Baby should be with the mother, and we should immediately cord clamping should not be done. It should be a delayed cord clamping. So we should always follow the previous slide. Previous slide, please. And WHO TAFE childbirth checklist should be definitely whether the mother need referral, partogram has to be there, and vaginal examination, sterile glove should be there for each vaginal examination, and birth companion should be present. Next slide. And just before labor, we should find out whether any allergy, any medication has to be given, and prepare the mother immediately after delivery, whether baby is single or multiple, and care of the baby is very, very important. Next slide. Next slide. Soon after birth, within 1 hour of birth, baby should be breastfed. Skin to skin contact is very, very important. Next slide. Before discharge, we should always find out whether the mother's blood pressure is normal, bleeding has come under control, baby is breastfeeding properly, and family planning options should be given to the mother. It's in government hospital, almost 100% coverage with the postpartum IUCD is followed. And surgical safety checklist should be ensured before taking the patient for cesarean section, whether they are signing in, any anesthesia consent is there, time in, time out, everything has to be properly documented. These are all very, very important for Lakshya certification. Next slide. These are the pictures from IOG. We have a clean labor room. Next slide. You have to ensure privacy to the patients. Next slide. Clean newborn corner, very, very important. The newborn corner is very important. It should have a proper biomedical waste disposal. Next slide. And clean hands. You should know the 6 steps of hand washing. This is very important for safe childbirth, safe surgical procedure, and we should ensure correct methods of hand washing. Next. And also sterile delivery instruments tray. Each delivery, each single tray, autoclaved. It should not be reused. It should be properly washed, cleaned in hypochlorite, and then washed again, and then autoclaved. Next. And always have a PPH corner. PPH drug list should be in one tray. It should be properly displayed how to manage a PPH. Earlier I said the condom tamponade is very, very important. Condom tied to a Foley's catheter should be kept ready. Next. And the right to have, every woman has the right to have a safe and free delivery services. We should ensure that. We should ensure adequate blood supply is available. Every delivery unit should have at least 2 obstetric ICU beds. And biomedical waste management cornerstone of any program or any protocol or any guidelines. Unless and until you dispose the biomedical waste properly, segregate most of the thing, whatever protocols we have will go waste. Next. And audit, very important. Whatever we do, we have to analyze, we have to criticize, we have to correct ourselves. Audit helps in that way. We have the primary LSCS audit, we have the maternal death audit, we have the NEOMS audit, we have the perinatal asphyxia audit. we have the neonatal mortality audit, and we have a CMOM coordination meeting, very, very important, where almost all districts of Tamil Nadu are connected through online, or if possible, they will come in person, and whatever mistakes they have done, it will be told to them and ask them not to repeat. In fact, this is very important point to improve the maternal and the neonatal survival. Next. So this is a very, very important, last but not the least, patient satisfaction form. We have to give the form and we have to tell them whatever they feel about the hospital, whatever the defects we have, whatever the wrong things we have done, they all will write it. This is to self-assessment. We have to critically assess ourselves. This patient satisfaction score is an important component of Lakshya certification. Next. The scope of services, another one important. Whatever we do, whatever is available in the hospital, we have to display at the entrance what is offered here, and the signages and the boards are very, very important and should be in the language where the patient can understand. And this is the new one, the safe unique care for mother and newborn, the Suman, which is widely practiced throughout Tamil Nadu, of course throughout India. And this is all about giving the TT and safe birth checklist, and counseling and contraception and free drawback services, and giving monetary benefits to the mother, and ambulance services for pregnant mothers, and also on-call direct transfer of maternity benefits through the NEFT. We are not giving cash in hand. Every benefit is transferred to the bank. And the PICME registration, early registration, pregnancy infant cohort monitoring, very important. And all the 102, 104, 108 is available to the patient anywhere, any place inside Tamil Nadu. Next. So the Lakshya intervention is again a quality improvement cycle, and following the clinical guidelines, pathways, protocols, and checklist is very, very important. You can see in the picture there are lots of IEC materials in the waiting room, all in local Tamil language, so that the patient and the attendants in the waiting room, they can just go through it and see what are all the things available. It's an IEC material. Display is very important in all the hospitals. Next. So this is the outcome, Lakshya certification, state and national level certification. Next. So nothing is possible without the staff nurses, and even though we are doctors and we are well qualified, of course you are our backbone. So I thank each and every one of you to have given this opportunity to us and help us in our hospital and throughout Tamil Nadu to reduce the maternal and the neonatal mortality rate. Thank you so much.
Thank you, Dr. Vijaya, for throwing light on causes that can lead to MMR, and also giving us solutions to bring about a reduction in this, and also giving us some ideas about interventions for care during labor and childbirth. Thank you so much, ma'am, for spending time with us today. Maternal and infant nutrition is a topic which is always, can generate ideas and policies to reduce maternal and infant mortality rate. To deliberate on this, I now invite Dr. Ramanarayan, independent consultant, community nutrition, to speak on the dynamics of this conference. Rama, ma'am? Ma'am, can you please unmute?
Thank you very much. Am I audible?
Yes, ma'am.
Oh, thank you very much for the kind introduction. And actually, both the presentations by Dr. Dinesh Kumar and Dr. Vijaya have already set the tone of the conference, and so that has made my job much easier. What I would like to do is to give a brief overview of why we chose to organize the conference on this theme and what were the other dynamics that were involved. Maternal and infant nutrition, it is a unique subject because it simultaneously engages with two entities, namely the mother and the young child. It is probably the only period in the life cycle which poses a continuum of care, that is starting with pre-pregnancy, then the prognosis of the pregnancy, the birth, that is followed by lactation, and then the introduction to complementary feeding. The range and complexity of issues to be addressed during this phase involves a multidisciplinary approach with a variety of actors and domains. Now, prior to pregnancy and during pregnancy, the health and nutrition of women is important, not only because of the birth outcome. Irrespective of the birth outcome, the women's health for her own sake is very important. Here, the family plays a very critical role in ensuring that the mother has access to a good diet, a balanced diet, has adequate rest and care. The role of the state is equally important. We just heard Dr. Vijaya elaborate on all the initiatives that are being taken at the hospital for safe delivery and for preventing the neonatal death. It is important in providing effective antenatal support by way of monitoring the health of the mother, providing supplementary feeding and other supplements, and also the needed vaccinations leading up to a safe delivery. Maternal and infant mortality have been the focus of research and policy for several decades, and even now they are considered as important development indicators to gauge the health of a nation. Once the survival is ensured, then the birth outcome determines the health and nutrition trajectory of the individual for the rest of their life. The birth weight is a very important determinant in the infant's growth. Research has helped us see that low birth weight is not only a causal factor for undernutrition, but also leads to obesity and diabetes mellitus in later life. The journey from being a newborn to infancy is rapid, involving several transitions by way of growth and development. Food and feeding occupy a central role. From being exclusively breastfed for the first 6 months, the infant is introduced to other foods. The mode of feeding also changes. From suckling, the infant goes to eating from a cup or a spoon, and even perhaps to hand feeding, as it is done in several parts of the world. Complementary feeding that demands skill and investment in time and patience on the part of the caregiver. The journey to infancy and toddlerhood is also paved with several episodes of illnesses, the commonest being the respiratory tract infection and diarrhea. A satisfactory prognosis of pregnancy means adequate pre-pregnancy weight, optimal weight gain during pregnancy, safe motherhood, a desirable birth outcome for the infant. Then this has to be followed by adequate growth and development. All these have involved and will continue to involve enormous amount of scientific research, optimal practices, effective public policies, and the cutting edge of technology, especially communication. While maternity and childcare are one of the most heavily researched and discussed topics, nevertheless, the range and complexity of issues that they include, along with newer challenges and a changing environment, make it imperative to continue with the knowledge exploration through research, its translation into practice, and advocacy for appropriate policy measures. It is in this context that the present conference is being organized. When we started discussing about how we would go about it, one of the approaches that was adopted in the design of the program was that the exposition of scientific advancement had to be parallel with the challenges faced. We were very clear on this point. The COVID-19 pandemic has shown what benefits we can reap as a result of investing in scientific research. Several decades of scientific innovation and research have enabled scientists and biopharmaceutical researchers to respond quickly to the development of vaccines and treatment protocols. At the same time, it threw up the problem of access to healthcare, especially by the poorest. The closure of public institutions and programs such as the Anganwadi or the early childhood centers and schools meant that even the basic vaccinations for pregnant women and children, as well as the direct feeding programs, got derailed. Access to health facilities was affected due to lack of transport that led to the revival of the demand for decentralized health services. This has taught us an important lesson. Advances and challenges are two sides of the same coin, and they need to be considered together. To the extent possible, we have tried to accommodate these two. Dr. Soumya Swaminathan, the Chief Scientist of World Health Organization, will be giving us a special address on the advances in maternal and infant care nutrition. And Dr. Yunus of the World Food Programme will share with us on the challenges in complementary feeding under special circumstances. Another approach in the design was that the setting has to be global. Once again, the present pandemic has taught us that the entire world is one global village. What happens in one place has implications for all. It is not that we did not know it earlier, but we were starkly reminded and jolted out of our complacency to take action. It is worthwhile to understand the scenario in other countries that are in a similar economic situation and how they have progressed over a period of time. We could learn from these experiences and perhaps apply them in our own situation. Dr. Usha Ramakrishnan, Chair, Professor of Global Health from the Rollins School of Public Health, Emory University, will give an overview of trends in maternal nutrition in low and middle income countries. Another dimension considered important was that theories have to be rooted in actual practice. In putting theories to practice, the health personnel have to contextualize it in the social, economic, cultural, and political milieu of the participants whom they serve. They get an opportunity to fine-tune the theories and techniques and make them workable in the given context. Their experiences offer guidance on how such situations can be addressed, and they also throw light on the kind of policy advocacy initiatives that need to be undertaken. We have already had Dr. Vijaya expound a lot on preventing maternal mortality and infant mortality and the kind of policy advocacy that can be taken up even in a clinical care setting. Dr. Yagnik, Director, Diabetes Unit, KEM Hospital, Pune, will provide us a lot of insights through his experience into the continuum of maternity and birth outcome with his presentation on maternal nutrition and low birth weight. His presentation would focus on the continuum that I earlier talked about, transition from the mother and to the child, as well as his own experiences in handling these issues. Another lesser known topic of undernutrition in the first 6 months will be dealt with by Dr. Praveen Kumar, Director and Professor of Pediatrics at the Lady Harding Medical College and associated Kalavati Saran Children's Hospital. He will elaborate on the management of acute malnutrition in the first 6 months. So long, all the policy focus as well as the advocacy measures, the programs are focused on the propagation of breastfeeding during the first 6 months, and not much attention has to be paid to the young child. Now, the reasons for acute malnutrition in the first 6 months, whether it is due to preterm or whether it's due to low birth weight or whether it's due to faulty feeding practices, and how to go about addressing these issues will be addressed by Dr. Praveen Kumar. The role of government in providing supportive policies and programs in ensuring the continuum of maternity and early childcare support will be expounded by Mrs. Amutavalli, the Director cum Mission Director of the Integrated Child Services Program. The ICDS is one of the largest and oldest programs for early childhood care and education in South Asia, with predominantly indigenous funding. The program tried to include, as far as possible, multiple stakeholders, from the academics to the practitioners to government and to the United Nations systems. It is hoped that this will provide an overview of diverse settings, perspectives, and practices. The conference, organized in the virtual mode, could perhaps lack the excitement and the personal and professional exchanges that accompany face-to-face interaction, not including also the technical glitches. Nevertheless, it provides an opportunity to bring together and listen to a galaxy of experts with vast experience within the available limited resources. The poster session, also organized in the virtual mode, encouraged participation from various parts of the country, including Mysore, Tirupati, Chennai, Ludhiana, to mention a few cities. We hope you enjoy and benefit from the program, and we look forward to receiving your feedback. And once again, apologies for all the technical glitches, and hope from now onwards we will have a smoothful transition without any problems. Thank you.
Thank you, Dr. Rama. I think in a nutshell, you have conveyed what the whole conference is all about for today and for tomorrow. Thank you so much. And for our next speaker for today is a very distinguished and well-known resource person, Dr. Chitranjan Yajnik, Director, Diabetes Unit, KEM Hospital, Pune. I call.
Sorry, you are not audible. You are not audible.
Oh, I'm sorry. Our next speaker is Dr. Chitranjan Yajnik, a very distinguished and a very famous scientist, very well known. He's a director, Diabetes Unit, KEM Hospital, Pune. And I request Dr. A.J. Hemamalini to introduce our speaker for this session.
Good afternoon, respected dignitaries and audience. It's my proud privilege to introduce the next speaker of the session, Dr. Chitranjan Yajnik, for our international conference. Dr. Yajnik is Professor and Director, Diabetes Unit, KEM Hospital and Research Center, Pune. And he is also Adjunct Professor, IISER, Pune, Visiting Professor in Molecular Medicine, Exeter, UK, Visiting Professor, Danish Diabetes Academy. And Professor's research interests have been high susceptibility of diabetes in Indians, intra-uterine programming of diabetes, and vitamin B12 and 1-carbon metabolism. Professor has been a recipient of number of awards, and to highlight some of them, Helmut Mehnet Award of the International Diabetes Federation 2009, David Barker Medal of the International Dohad Society 2011, Outstanding Investigator Award of the World India Diabetes Foundation 2016, 41st Gopalan Oration Award, Nutrition Society of India 2017-2018, March of Dimes Agnes Higgins Award 2019, Stanford International Ranking Top 0.4 person in diabetes. His publication totals to 303, out of which 79 as first author, and research articles have been around 150. Professor has authored 56 review articles, 6 chapters in different books, and the rest of them are others, 87 numbers. We are happy to be listening to you, Professor, and over to you. Thank you. Oh my God.
Okay, good afternoon, everyone. Are you able to see my slides?
Yes.
Yes, sir. Yes, sir.
Thank you. Thank you for the invitation. Great privilege to speak to you all. And I just picked the topic to say it's going to cover nutrition, both of the mother and baby, baby's birth weight, and the health prospects which it brings on. I work in the KEM Hospital, Pune, and this is the only diabetes unit in the world which has mother and baby as the logo. And that is what you can see here. Our new logo is this modern Ganesh, who instead of traveling on the back of this mouse as he used to do when we were children, he now clicks the mice and enjoys the modaks that are next to him. And that's the rapid transition we had in our lifetime. And we have collaborators across the world, notably David Barker's unit in Southampton, the MRC Life Course Epidemiology unit, and other units. So I wrote my confessions in 2017 in European Journal of Clinical Nutrition. And I wrote how I got involved in nutrition. But important to note that I am not an epidemiologist. I'm not a nutritionist. I'm not a pediatrician. I'm not an obstetrician. But still you have invited me. I am a poor diabetologist, but I was weaned on the dogma that large babies born to diabetic mothers are at higher risk of diabetes. So that is what I was trained when I was learning medicine and diabetes in 1970s and early 80s. The situation changed one day in February 1991 when Professor David Barker came to meet me in Pune. And that time he brought a copy of his paper, which was going to be published soon in BMJ. And what he said to me was that in his path-breaking study, which was the Hertfordshire study, he had found an inverse association of birth weight with risk of pre-diabetes and diabetes, and also with what that time was called syndrome X. Today we call it metabolic syndrome. In other words, if you are born with a smaller birth weight of less than 5.5 pounds in his cohort, the risk of diabetes at 65 years was 40%. On the other hand, if you were born more than 9.5 pounds, the risk was approximately 10%. So four-fold increase in risk of diabetes if your birth weight was less than 5.5 pounds compared to 9.5 pounds. And in the very first meeting, I suggested to David Barker that he call his hypothesis thrifty phenotype, which he kindly did. And he wrote it 2 years later, saying that type 2 diabetes is the outcome of the fetus and early infant having to be nutritionally thrifty, that it had to be clever in managing the nutrition if it was not good when it was growing in the mother's womb. So that was the thrifty phenotype hypothesis, and it was exactly opposite of what I had learned as a diabetologist. Then I started thinking about this and came across some remarkable papers from UK written by Elsie Widowson and a colleague McCants. So what they had written was that the size attained in utero depends on the services which the mother is able to supply. These are mainly food and accommodation. And that is how I converted this into a term called bed and breakfast. So it's the bed and breakfast situation in utero which determines the size of the baby. Bed, basically the size of the maternal pelvis, because baby cannot grow bigger than this. And the breakfast comes through the placenta, but is basically the nutrients carried in mother's blood. So these two issues, the circulating nutrients in the mother's blood and her pelvic size and the skeletal size, are the major determinants of the fetal growth. And what has happened in India, this is quite a remarkable slide taken from the WHO study of height across different populations over last 150 years, from let's say 1820 to approximately 1980. And I have plotted 6 countries, 3 in Europe, 3 in Southeast Asia. And the yellow line is India. In Europe, in these 150 years, there was a 15 centimeter gain in height. India gained 0. And some of the Southeast Asian countries lost height for substantial periods of time. So that's the vast difference in the height gain in European versus Southeast Asian countries. And we can ascribe this to the strong ecological stresses that operated in Southeast Asia related to food supply, occupation, weather changes, hygiene, and whatnot. You are familiar with the NFHS data. I have just summarized it. Between NFHS2, which was in 1998 to 99, and NFHS 5, which was recently, like say 2019 to 2021, India has seen a progressive decline in underweight in the mothers. It has seen a worrying increase in overweight and obese during same time. Similarly, under 5 undernutrition, underweight and stunting have progressively decreased. Wasting has probably remained same because it's a sort of relationship between the stunting and underweight. But as a nation, we are now progressively becoming less undernourished and more overnourished, and this is the nutrition transition. As I will say in few minutes, it also brings in a double burden of malnutrition. And this is what I wrote for the Lancet series in 2019 with my friend Jonathan Wales, then the brilliant sort of Brazilian scientist Ana Savaya, and other members of the panel. We wrote quite detailed mechanisms and etiological pathways in this double burden, which will have consequences for health, and I think you should perhaps read this. I also wrote an editorial for American Journal of Clinical Nutrition on fetal adiposity epidemic in the modern world, and this was based on our work of the thrifty phenotype in Indians, and which now is exaggerated by maternal obesity and diabetes in relation to fetal adiposity. So these are some central issues about double burden of malnutrition. And this is a figure I have taken from the Lancet review. It is based on Pune research in 3 cohorts: the Pune maternal nutrition study, which is our rural birth cohort; Pune children study, which is our hospital-based birth cohort; and the GDM cohort are about 1,000 women treated for diabetes and pregnancy in my department. And what we saw was progressively the maternal mean BMI in these 3 cohorts has increased from 18.5 to 20 to 25. Similarly, the F1 babies have changed. In the village cohort, 54% were SGA. In the urban cohort, 35%. And in the diabetic pregnancy, 22%. This in itself is remarkable compared to Western literature, where you won't see SGA in diabetic pregnancies. You will predominantly see LGA, and our LGA is as expected, around 10%. So we are still dealing with the legacy of low birth weight, even in the diabetic pregnancy. And we have now followed second generation in the village cohort, and we have some interesting findings, which I'll discuss a little later. All these ideas actually led David Barker and us to think about the phenomenon which David Barker called fetal programming of adult disease. And what it was based on was that during development, the fetus will grow healthily in different directions as required by the situation to fulfill its genetic potential. And this is called the plasticity of the growth. Plasticity allows you to grow, into quotes, wildly to achieve the genetic potential. If there is actually a restriction of this plasticity by any adversity, then that leads to reduction in the growth and you cannot achieve the genetic potential. And that is what basically is fetal programming. Programming is loss of plasticity, and it can lead to lifelong effects on structure and function, and that can have implications for disease. The windows of vulnerability and therefore also opportunity are pre and periconceptional period. Hardly any woman comes to a doctor or to the system during this time. Then pregnancy itself, lactation, and first 2 years, the so-called catchy term of 1,000 days. And interestingly, genetic and epigenetic mechanisms decide what happens in programming. Some of the known programming environmental factors are maternal nutrition, or metabolism, or stress, pollutants, and a whole lot of other things. As I showed you in our height slide, this is a multi-generational problem. But the hope is that if we do right things, then it might be reversible. And this can be demonstrated not only in the whole organism, but in the systems, organs, tissues, cells, and in molecular terms. And as we started working in last 30 years, starting with organism, we have now come to some molecular observations in our studies. Another interesting phenomenon in fetal growth is so-called brain preservation. In an adverse condition, the body's mechanisms will adapt in the developing system to maintain the brain growth. And in the bargain, it has to let go growth of some of the organs. And depending on the window in which the challenge occurs, different systems can be affected. So brain blood supply is maintained by what is called pre-ductal diversion of blood flow. And therefore post-ductal structures, including cardiovascular system, liver, muscle, kidney, pancreas, they all suffer. And if you just think within your mind, that affection of these organs is what we call non-communicable disease epidemic. So an intrauterine adversity which tries to maintain the brain growth will necessarily lead to poor growth of other organs, and that might predispose you to problems in later life, what we call non-communicable disease, if the load of the system becomes too much. When I was training, there was this fantastic scientist in Chicago called Norbert Frankel. And he had said similar things about diabetic pregnancy, but coming from overnutrition side. And he said in a diabetic pregnancy, mother feeds the baby extra fuels. That's glucose, amino acids, and lipids. These mixed nutrients stimulate the pancreas of the baby to make more insulin. Insulin is a growth hormone in intrauterine life. It leads to macrosomia. It leads to hypoglycemia in the neonatal period. But very interestingly, he said this also leads to future obesity and diabetes in the child. And he called this fuel-mediated teratogenesis. And he showed windows in the pregnancy that in early pregnancy, organogenesis, in mid-pregnancy, behavioral, and in late pregnancy, anthropometric and metabolic programming can happen. This is, of course, a very simplistic thing written 50 years ago. We now have many more ideas in this. But Norbert Frankel came to this from overnutrition side. David Barker came from undernutrition side. And then I added the role of micronutrients in this by showing that micronutrient nutrition of the mother, especially of one carbon metabolism, B12 folate, B6, B2, choline, B10, can affect the fetal growth. And therefore, usually it is a combination of macronutrient and micronutrient problems, sometimes excess of one and deficiency of other, or sometimes deficiency of all. And this affects the metabolism and structure profoundly. So to do all these studies, we set up Pune Maternal Nutrition Study in 1993 with help from David Barker and Caroline Fogg. We went to 6 villages near Pune, enrolled all women who were married but not pregnant, and there were more than 2,500 of them. We studied them every month for their anthropometry. We studied them for their menstrual cycle dates, and those who became pregnant, we studied them for their fetal growth, for their nutrition, for their metabolism. We also studied fathers, and we had data on 814 such pregnancies in these 3 years. Babies were born, which were measured in detail at birth, and then every 6 months for 18 years, and then every year subsequently. And every 6 years, we study the babies and the parents for their body size, body composition, nutrition, cardiometabolic risk, cognition, and whatnot. Our last follow-up started in 2019. That was 24-year follow-up. It had to be stopped in 2020, but we are hoping to start it next month. So we have studied about 250 out of possible 700 by February 2020. And we also created a blood bank, biobank of mothers and baby samples serially. So we have a very rich biobank starting from 1994 now on to 2022. And what were our findings? The mothers were on average 42 kg with a body mass index of 18.1. They were quite short at 1.52 meters. They were predominantly vegetarian. Their intake was only about 75% of the recommended allowance. Carbohydrates form large part of energy, 72%. There was a lower intake of green leafy vegetable, milk, and fruits, 3 food items which are rich in micronutrients. And they had very substantial physical activity, not only in early and mid, but even in late pregnancy. We had done glucose tolerance test on these women, and less than 1% were gestational diabetic in 1994 to 96, but 2 out of 3 mothers were B12 deficient, and occasional mother was folate deficient. And we described the thin fat Indian babies in this. I'm not going to go into details of that, but in summary, what we showed was a 2.7 kg Indian baby had more fat compared to a 3.5 kg English baby. And this was obvious on anthropometry and importantly on whole body MRI, which was able to compare the 3 compartments of fat in the abdomen, which are all higher in Indian babies compared to the English babies. The thin fat baby has become an Indian concept. Recently, I am now able to publish a result of comparison of twins with singletons born in Guinea-Bissau, which is a West African country, and I was given this data by my Danish collaborators. And what we showed was that here now the blue line is a twin and red line is a singleton. And we studied approximately 300 of them across the age range of 5 to 35. And what we showed was that the singletons had, or let's say twins had a lower BMI compared to the singletons. But interestingly, if you look at skin folds, the skin folds were higher in the twins compared to the singletons. And if we calculated body fat percent by using some formula, that was also higher in the twins. So twins are indeed thinner, but fatter compared to singletons. And therefore it tells us that intrauterine division of nutrition between two between 2 individuals can also lead to thin fat phenotype, and therefore it is a nutritional phenotype rather than being an ethnic Indian phenotype. We also showed in PMNS strong associations within normal range of maternal fasting and 2-hour glucose with different anthropometric measurements, and also offer circulating cholesterol and triglyceride levels. So macronutrients into quotes normal level affected fetal growth strongly, as did micronutrient-rich foods like GLV, green leafy vegetables. RCF is a red cell folate. And this is a plot of homocysteine, which I will explain to you after I tell you what this means. This shows that green leafy vegetables and also milk and fruit frequency of consumption was strongly related to birth weight of the baby. Maternal folate was strongly related to birth weight of the baby. But interestingly, high homocysteine in the mother at 28 weeks gestation strongly predicted small for gestational age baby. So high homocysteine, which largely came in this population from B12 deficiency, was a predictor of small for gestational age. So it is a combination of macronutrients and micronutrients, adequate and inadequate, which gives rise to or contributes to the birth weight of the baby. And when recently we studied glucose tolerance of these babies who are now 25 years old, this is the data at 18 years old, we found that pre-diabetes at 18 years was predicted by being short at birth, having small head circumference at birth, and also disturbances of 1-carbon metabolism. At the same time, it was also predicted by maternal pregnancy glucose, even though in the normal range. So mothers who had higher levels of glucose within the normal range, their babies had higher risk of prediabetes at 18 years of age. And fathers who had diabetes, their daughters had higher risk of prediabetes at 18 years of age. So a double burden of malnutrition in a life cycle, undernutrition and undergrowth in utero, but higher exposure to maternal glucose and paternal glucose actually combine to increase the risk of prediabetes. And maternal B12 and folate interacted in such a way that low maternal B12 and high folate at 28 weeks increase the risk of diabesity in the baby, such that this combination of nutrition in mothers was associated with higher risk of adiposity and insulin resistance in the baby. It was also associated with brain growth, and we have a very interesting story coming out through a DBT Wellcome Association fellow in our department who is doing fantastic work on brain growth in relation to vitamin B12 exposure in utero. At the same time, we have followed up children born in diabetic pregnancies in my department and showed that babies born to diabetic mothers have a considerably high risk of being diabetic or pre-diabetic at 15 years of age compared to those who were born in non-diabetic pregnancies. And this was demonstrable even earlier, that means from 2 to 10 years of age. In other words, poor intrauterine growth on one side and exposure of higher maternal glucose concentrations, either in the normal range or in the frank diabetes range, increases the risk of future prediabetes and diabetes. A very interesting double burden, intrauterine double burden, increasing the risk of problem in the baby. And therefore, we are now more and more interested in epigenetic regulation of fetal programming, for which there are 3 described mechanisms: DNA methylation, histone modifications like acetylation or phosphorylation, and circulating miRNAs. And we are now just now doing many studies in all these fields. In the genetic side, we have a very interesting paper which was published last month in the Diabetes Journal, where as a part of an international collaboration called GIFTS, we used genetics of birth weight and showed that the genetic risk score in Europeans and Indians was very similar. But despite similar gene risk score, the Indian babies at the bottom here have a lower birth weight compared to English babies, which are in blue here. So for same genetic makeup, Indian babies are growing smaller. And this is indicative clearly of a strong environmental influence. And I have discussed some of these with you in the previous slides. So we are now doing a number of molecular studies, including DNA methylation. We have done fantastic studies in gestational diabetes and found some differential methylation of certain genes which increase risk of obesity and diabetes in the child. In a B12 trial, we have had very interesting results in transcriptome, whereby we showed that B12 supplementation influences cell cycle affecting gene transcription. We are also now doing studies of placental transporters for glucose, fatty acid, amino acids, B12 and folate, and have interesting results to show how placenta adapts to maternal nutrition. And we are studying maternal adipocyte-derived exosomes in pregnancy to see how they affect adiposity in the infant. So a lot of interesting mechanisms coming out. I'm very proud that we are able to do these studies, and 3 of these 4 studies are already on way to be published. Another study, international collaboration with my Oslo colleagues, made a remarkable finding based on findings in Pune. What we had shown was that the Indian thin fat babies have higher leptin concentration in their cord blood compared to the English babies. So in Oslo, we were able to show that these 13 different CPG sites in the leptin gene are differentially methylated in the South Asian compared to the European babies. So these pink bars or orange bars are all South Asian babies, blue are European, and at each of the 13 CPG sites in the leptin gene, the South Asians have differential methylation, indicating that placental structure and function might be affected by the different environmental factors which operate in the South Asian pregnancies, and we were able to relate it to circulating glucose, cholesterol, B12, and other micronutrients. So what I have told you is that pregnancy is perhaps the most important time in one's life. Pregnancy when you are growing in the mother's womb. That is before your birth date. And it's an experience for the two, for the mother and baby. I'm going to ask the students, the PhD scholars and the postdocs in the audience to see whether they know of what I am going to tell you just now. This mother is pregnant with a female child. And the female child in the ovary will have all the 100,000 ova which it will ever have in her life by 20 weeks of gestation. So these ova are deposited between 10 and 20 weeks of gestation, so that a pregnancy with a female child is actually an experience for the three. And this now, instead of intergenerational, becomes a transgenerational experience. So female child is important not for social reasons, but even biologically, it has such a huge impact on the subsequent generations through the mother's nutrition, through fetal programming, that we need to be extremely careful. Now, this is slightly interesting thing that after I gave a talk in one of the European conferences, one very austere looking lady from Poland came and shook my hands. She said, I am the dean of the University of Poznań Medical High School, or medical faculty, dean of medical faculty. And she said, do you know what Jajnik means in Polish? It means ovary. And therefore, I relate this coincidence with the 3-generation transmission through ovarian development in utero. So that's slightly humorous, but I think that's a great coincidence which brought me into this field. And finally, I'm going to say the president actually showed this slide. about double burden of malnutrition, which I published in 2009 and called it dual teratogenesis. So there is an undernutrition cycle and there is an overnutrition cycle. And within last 40 years, India is rapidly moving from these two, one to the other, but not forgetting the legacy of old malnutrition. And therefore, there is a dual teratogenesis in India of a condition like diabetes. And that is why we have become one of the world's capital. And we have such fantastic data in Pune maternal nutrition study that the girls born in the cohort between 1993 and 96, more than 180 of them have now produced their own babies. And we are able to show that between two generations, there is a 250-gram increase in birth weight. There is a 0.7 centimeter increase in height, 0.2 centimeter increase in head circumference, abdominal circumference 1 centimeter. But very rewardingly, the skin folds have not increased. I would like to think this might be partly attributable to the Priya trial, which we did in this F1 generation by supplementing them with vitamin B12 and micronutrients from 17 years of age, preconceptionally. And the trial has gone on for 8 years and we closed it in February 2020. You will see a lot of interesting papers from this. Finally, I'm going to advertise that you should all go to YouTube, KEM Hospital Pune. Watch this film, which is a fantastic film made by Mrs. Sumitra Bhave in collaboration with a famous actor Mohan Agashe and Dr. Chittaranjan Yadnik, who provided his research findings. And Mrs. Sumitra Bhave has produced a fantastic film called Sakre Peksha Gold. So I invite you all to watch the film and learn about the importance of maternal nutrition for the next generation. And finally, I want to say thank you to all the participants in my study who are now grown up into young and beautiful worlds, the village staff, the collaborative group Sneha run by all of us, but David Barker is here, Caroline Fall should be here, and many other participants. Pallavi, my wife, my staff, and these participants when they were young with the booklet in their hand on which they insisted to sign their assent even as early as 6 years of age. So thank you very much.
Thank you, sir. It was a fantastic lecture. And I think every time, I think I'm speaking for everybody here, every time we listen to your talk, there is something new and there is so much insight into newer aspects relating to maternal nutrition. So I mean, it was like a very, very interesting and an intellectual deliberation that you have given us today. Thank you so much. Before I go on to a question.
One question in the chat.
Yes, sir. I'm
Dimple
just
has asked about B12 supplementation as part of IFA. That is exactly what I am advocating just now. And very soon I will submit a document to the government of India to suggest that we should include B12 2 micrograms daily in intake of adolescents. And how to achieve it, etc. will need much more research. But our trial using 2 micrograms per day achieved better neurocognitive performance between 2 to 4 years of age. This is published 2 months ago. And we are just now writing other papers about transcriptome change, miRNA changes, change in DNA methylation, etc. So yes, I entirely agree. And I hope NSI will support this basic thesis that B12 should be part of the supplementation. I know that Orange Rice is going to have it. So I think we should try to improve B12 status of young people through various routes, either by milk, non-vegetarian food, and we have recently shown that an algae called chlorella has B12 content which can be utilized by humans, and it improves your B12 status. So various routes of B12 supplementation for young girls and women in the reproductive age.
What about for vegetarians? Like if it is not in the diet, would you advise giving them a B12 injection?
Injection probably not necessary, because we have shown that more than 85% of people in our cohort absorb B12 quite vigorously. Okay. So injection is if you can't absorb it. Therefore, like in public health, we would like to improve the B12 intake from natural sources, but vegetarians can't take anything but milk as a natural source.
Milk is the
Therefore, we will have to use low dose supplements and use algae like chlorella, which will improve the dietary intake. So I'm going back to basics. Improve dietary intake. Don't think of injection unless there is a specific need for it. Otherwise, I mean, we can achieve, like say, coronavirus vaccination once in millions or in crores of people. You have to do this every month. In how many girls? It's practically impossible.
Impossible.
Yeah. So I would invite NSI to do more and more research in the field of low dose B12 supplementation and getting it right at a public health sort of level. And Dr. Lakshmaya is saying yes, so I am happy that it will happen.
Doctor, I have just one more query. You had spoken about gene score, which is lower for Indian babies compared to
No, it's not lower. Gene score was same, but birth weight is lower.
Oh, but okay. Is it associated with maternal overweight or obesity?
No, I mean, this is baby's gene risk score for weight. And what we show is that it has all the necessary genes in appropriate proportion, but there is not enough nutrition to grow in size. So this is a beautiful example to show that if we get things right, we will achieve a good birth weight. So there is no genetic inhibition, but it's all environmental. And one of the examples was about this height, which hadn't grown in Indians for 150 years. Between 1980 and today, now children are becoming 5 centimeters taller than their parents. So that inhibition or restriction of growth is gradually being removed.
Okay. Thank you so much.
Thank you, sir. Thank you, sir. It is a very excellent talk. Always we listen to you, love to listen. And as she said that every time you are telling some new thing, but it is very, very in-depth.
Yeah, that's my mission.
Yeah.
David Barker told me when I finished 6-year follow-up, yes, I went to him saying, now let me go back to diabetes. So he said, no, you need a daddy to tell you what you want to do. And I am your daddy. Yes. And David Barker said, don't leave Doha.
Sir, another 2 things. One is that B12 fortification, rice fortification also coming up. And another one, even IFA tablet also, the government is thinking to add B12 also along with IFA.
Right.
So these 2 things are may happen. So then probably it can solve the B12 deficiency to some extent. But as well as even diet also very important.
Yes. We are depending on you, Dr. Lakshmaya.
Yes. Thank you.
If there are no more questions, I don't see anything more. Does anybody have any questions? If you can post it on the chat box.
There is one in the chat box, ma'am, by Dr. Sudha.
By Dr. Sudha.
Yeah, there is a question. It says, is there any affordable technique to assess B12 to be implemented at community level? So I can tell you that B12 assays are just now in great disrepute. Dr. Lakshmaya and I are part of a multi-center study, and we know how we get very different results in different laboratories using different techniques.
Yes.
So there is a need for standardization of assay, which I think will take a long time. Assay is quite expensive. So what I suggest is that you do a study in community at a research level, find out if more than 10%, 15% of population is B12 deficient. If more than 5% deficiency, we say it is public health important. And then supplement everyone. Why do you want to measure everyone before supplementing?
Yes.
So I did a study in Pune and found that 50% of rural, 50% of urban slums, and 80% of urban middle class people in Pune were B12 deficient.
Oh, great.
So I don't need to check now. I can supply to everyone saying this is a public health statistics and we need to take action on that. So do research studies, find out the level of population deficiency and then act on it.
Thank you so much, Doctor. And
Thank you.
Excellent talk, and we have really gained so much today from your talk. Thank you so much. If there are any more queries, we will post it to you later.
Please do. And our website, Diabetes at KEM Diabetes Research Center, will give you all our papers and this.
Thank you so much.
And
Thank
I would urge you to watch that film made by Sumitra Bhave. It's beautiful.
Will do, and we will also post it in our group for everyone to watch it. Thank you so much, Doctor.
Yeah.
Thank you again.
Thank you. Bye-bye.
Bye.
Our next program for today is a book release. This came up as an idea when we had a lecture session last year by two eminent speakers, Dr. Usha Antony, Dean of Fish Nutrition and Food Technology, and Dr. Annie Kuriachin, Associate Professor and Head, Department of English, Women's Christian College. Since research is an integral part of any academic institution, we just had this idea of having these lectures published as a book. And this came to fruition recently, thanks to Dr. Lakshmaya's motivation and encouragement, and also help from Ms. Ruth Davida, who helped actually put the contents in a book form, and who has actually designed the book, and Ms. D. Dimple, a research scholar who also designed the cover page. I now request the authors, Dr. Usha Antony, Dr. Annie Kuriachin, Ms. Dimple, Ms. Ruth, to please turn on the videos. And I now request Dr. Sharifa to formally introduce Dr. Lakshmaya, who will be doing us the honor of releasing this book today.
Good evening. I'm very happy to welcome everyone present here to the release of the e-book, Writing a Technical Paper, co-authored by Dr. Annie Kuriachin, Associate Professor and Head, Department of English, Women's Christian College, Chennai, and Dr. Usha Antony, Dean, College of Fish Nutrition and Fish Technology, Tamil Nadu, Dr. J. Jayalalitha Fisheries University, Chennai. This book is a result of a webinar presentation organized by the Nutrition Society of India, Chennai chapter on 22nd January 2021. The positive feedback to the webinar was so overwhelming that it led to the decision to bring out this e-book. Dr. Lakshmaya, Secretary, Nutrition Society of India, has rightly pointed out in the foreword to this e-book that it is essential reading for every budding scholar, researcher, student, or professional working in research and development. It is my pleasant duty to thank both the authors for their willingness to translate this presentation into the e-book. I acknowledge with special thanks the contribution of Ruth Nayantara Davida, Life Member, Nutrition Society of India, Chennai chapter, who took immense care to edit this book, and D. Dimple, Research Scholar, Women's Christian College, who designed the cover and helped with the formatting of the e-book. Dr. Lakshmaya has been our mentor and guide. Without support every step of the way, the task of preparing this e-book for publication would never have been accomplished. Thank you very much, sir. We owe you a huge debt of gratitude. It is my privilege now to call upon Dr. Lakshmaya to officially release this book and say a few words.
Thank you, Dr. Sharifa, and giving this opportunity. I'm very much thankful. And I was also associated with book, and I reviewed the book, and it was very good and very nicely presented. And I'm also congratulate Dr. Sharifa for conducting that important seminar or webinar. And the outcome of the webinar written as a book, it is excellent. And this is a model for all the chapters also. We can, all the chapters, we are organizing several conferences, symposia, and other things. But ultimate output also should bring either a technical report or either write a paper or something. That should be a productive and it should be recorded also. So those issues, because we are really thankful for the Chennai chapter and their excellent performance. I also thank Usha, Annie Kurian and Usha Antony. So they have presented this book very nicely, and it is definitely useful for all the budding students, and not only budding students, it is also useful for even junior faculty, those who are recently joined, and how to write a technical report. And I also suggested Sharifa, and you can also conduct one more webinar on how to write a research paper. So the manuscript preparation and other thing, even that is also very important for all the students. So now I'm very happy to launch this book, and it is very. Shall I go ahead?
Yes, please.
Yes. So it has a very nicely come up also. Is it visible?
Yes.
Thank you once again. Congratulations, everyone. And it is a very nice book, and every student also, if time permits, please read this book, and you will get very good knowledge on this. Thank you for once again.
May I request Annie to say a few words, and then Dr. Usha.
Okay, thank you very much, Dr. Lakshmaya, for those encouraging words. It'll go a long way to help me write more books, especially in this interdisciplinary field that I was dabbling with, trying to do English or writing skills using the English language for this particular discipline, nutrition discipline. That was fascinating for me. And some of my examples are from the field of nutrition, thanks to very good friends that I have in the form of Dr. Usha Antony, Dr. Sharifa, Dr. Gauri, and my own student Dimple. I am totally indebted to all of them who traveled along with me for this interdisciplinary approach. Thank you once again to the Nutrition Society of India, Chennai chapter, for giving me this opportunity.
Thank you.
Usha?
Yeah. Good evening to one and all present here today. It's a very happy occasion. Thank you, Dr. Lakshmaya, for those kind words and for releasing the book. Today is a very happy occasion as far as the Chennai chapter of Nutrition Society of India is concerned, because we are organizing this international conference in the virtual mode. And in this occasion, to have this book released is a happy one for me, and I'm sure for Dr. Annie Kurian. And as mentioned earlier by Dr. Sharifa, this is an outcome of the webinar we had last year. And that was quite a lot of a learning experience for me also. And to work along with Dr. Annie Kurian, and then to make sure that we didn't overlap things, and each of us had some independent thing to say based on the information collected from literature and presenting it, was a learning experience. So that was very satisfying. And but for Dr. Sharifa Talha's push to get into it, it was her spark idea to put it forward, take it forward in the form of a book, which will be of use to several young students who wish to do their research and then get their research published. So, but for her, this would not have happened. Of course, Dr. Annie was there along the way, and two other people who really mattered were, one was, as Dr. Sharifa mentioned, Ms. Ruth Nayanthara David, who's also an alumnus of WCC and a member of NSI. And her work, even as a student, she's known for her meticulous work. And in this case, her meticulous work, the language editing she did, as well as the formatting and styling of the entire book has been really fantastic. Much more than at least my expectations. So I'm really thankful to her and to Ms. Dimple, who's also belonging to the nutrition department. So it's really wonderful that they were able to help us, support us. But for everybody's support, this would not have happened at all. So thank you all. Then, of course, it need not be, overemphasized, or I need to overemphasize, that should be the right thing to say, that it is the queries of my colleagues and students who have really helped, in any presentation. It makes us think from their point of view and to put things which forward in a way that will be useful to them. So I am indebted to all my colleagues and students who raise questions, who raise queries, and therefore make us think and make us better communicators, I should say. So thank you all once again for the support and making this possible. This would not have come to fruition but for the support and push of several people, including NSA headquarters through Dr. Lakshmaya. So thank you all once more.
Now, may I request Dr. Lakshmaya sir, please announce the result of the poster competition. Here, I'd like to mention, I would like to thank Hema and Isaac from Poru Ramachandra. Like, she only completely took care of the formulation of the template and also the guidelines for the poster. Actually, we had a good representation from Mysore, Kotti, Telangana, Puducherry, Ludhiana, Tirupati, and Chennai. Sir, I would request you to announce the results first, second, and third.
Thank you. Thank you, Dr. Sharifa and the organizing committee to giving this opportunity. I'm really privileged to announce this poster awards. And so there was a very good representation from most of the states for presenting their posters. And even though the prizes are given for 3 people, but I heard that all posters also very informative and innovative researches. And I congratulate everyone and especially those prize winners. So I announced that first prize goes to Ramsha Ayman. So, and her group, it is from Osmania University, Telangana, and Lata Sheshi and Aslesha Pandli. So the title of the poster is Impact of Maternal Education on Knowledge, Understanding and Attitude on the Use of Probiotics and Probiotics in Pregnancy and Child Health. So congratulations for this group. They are getting, they got first prize. And second prize goes to Asma Sajid and V. Premala Priyadarshini and Lata Shishi again. This is Avinash Lingam University, Coimbatore. So the poster title was Maternal Health Status of GDM Mothers at a Tertiary Care Center, Hyderabad, Telangana. Congratulations this group for getting second prize. And third prize goes Dr. Vanita Reddy P. and RH Akshata and Harini M. So this is JSS EHR Mysore, Karnataka. So the study on dietary habits and the lifestyle of pregnant ladies having gestational diabetes and hypothyroidism. So I congratulate all this, all the faculty or students of third prize winner. And once again, I'm very thankful for coming and presenting their posters. And I once again congratulate all the prize winners. Thank you.
Thank you very much, sir. Over to you, Gauri.
Thank you, Dr. Lakshmaya, for releasing the book and also giving us the winners for today's poster competition. Congratulations to all the winners. We now move on to our next program, which is the talk by our international speaker. We have with us Dr. Usha Ramakrishnan, a very eminent person. She is the chair and professor of Global Health, Hubert, Department of Global Health, Rollins School of Public Health, Emory University. We are extremely grateful, ma'am, because I know it is like very, very early for you today, and you are here with us despite the time difference and also getting up so early to address our dignitaries here. I now invite Dr. Usha Antony to introduce our speaker, Dr. Usha Ramakrishnan.
Yeah, once again, good evening to everybody present here to attend the seminar. It is both an honor and privilege to welcome and to introduce Dr. Usha Ramakrishnan, an eminent international nutrition expert. I'm proud to say that she is one of the alumnus of Women's Christian College, Chennai. And needless to say, I was excited when her name was suggested as one of the speakers. The Usha Ramakrishnan, who I knew as an enthusiastic student and budding researcher, has bloomed into a distinguished professional at the global level, leaving the alumnus of WCC and having chartered a very distinctive path for herself. Dr. Usha Ramakrishnan is currently the chair and professor of global health at the Hubert Department of Global Health at Rollins School of Public Health, Emory University, Atlanta, USA. She completed her bachelor's and her master's in food and nutrition from the University of Madras. Her doctoral degree in international nutrition is from Cornell University, Ithaca, New York. She has many honors and awards to her credit, which include several fellowships, like the one she got from the University of Madras, the Merit Scholarship as early as 1985, and then the Ethel B. Waring Fellowship from Cornell University, 1989, and the Esther M. Rest Fellowship from Cornell University, 1990. At WCC too, she bagged many awards for her master's program, excelling in biochemistry and food science, as well as the master's thesis in 1985. Several other awards which she has include the Young Investigator Award from the Society of International Nutrition Research in 1993, the Norman Kretschmer Award from the American Society for Clinical Nutrition in 2003, the Marion V. Creekmore Award for Internationalization from Emory University in 2020. And I think more recently, the Kamala Puri Sabharwal Memorial Lecture Award from Lady Irwin College at New Delhi. Her vast professional experience spans from as early as 1986 till date. She served in many capacities in several institutions. As a graduate faculty and adjunct faculty at Sri Ramachandra Institute of Higher Education and Research in India, INSP, that is the Instituto Nacional de Salud Pública in Mexico, the doctoral program in Nutrition and Health Sciences at the Laney Graduate School, Emory University. And prior to this, she served as research investigator, graduate research assistant, research associate, research assistant professor, associate professor at the Department of International Health in the Hubert Department of Global Health, Rollins School of Public Health at Emory University. The trajectory moves on, and finally now she moved as professor, vice chair, interchair, and finally chair and distinguished Hubert Professor of Global Health at the Rollins School of Public Health in Emory University. Her research activities have led to several publications in indexed and peer-reviewed journals, which number close to about 200, several book chapters, books, monographs, and proceedings, which all speak for her work. Of course, she has made innumerable seminar and conference presentations as an invited speaker. This also crosses and comes close to, I think, 250. Her expertise in teaching and in research and her service to society is reflected as in her service as member and chair in several committees at the Rollins School of Public Health at the Emory University and several other international bodies like the CDC, WHO, the Gates Foundation, the National Institutes of Health, the WHO, SCN, UNICEF, American Society for Nutrition, and Public Health Foundation of India. She's also a reviewer of grant applications and she serves in several panels at her university, that is the Emory University, as well as National Institutes of Health, the Nestle Foundation, and several others. So thank you, Dr. Usha Ramakrishnan, for accepting our invitation and managing to make the time and the space for this presentation and for gracing the occasion. We look forward to your presentation. I'm so happy I'll be able to see you at least on screen for a short time now, and of course, listen to you. Thank you.
Thank you very much. I hope you can all see and hear me in this 21st century way of, I wish I could be there in Chennai in person. Is the volume good? Just to
yes,
ma'am.
Yes, we can hear you.
Perfect.
Clearly. Yes.
Thank you. So first I want to thank Dr. Gauri Ramesh and the organizers for reaching out to me and inviting me to this really important presentation and conference. This is very close to my heart, and I could not ask for a better person to introduce me. How many of us have the privilege to have a former professor, mentor? I still think I'm only 19, but I know time has gone by. It really is extra special and sweet to when Dr. Usha Anthony sent me an email, and can't say no, right? But I wasn't going to say no anyway. So without further ado, I would like to proceed into my presentation. And this is really a topic that has and continues to be close to my heart from the days that I went to the field years ago. I do want to especially acknowledge Dr. Pratap Kumar, who's no longer alive, was my thesis advisor when I was at WCC, who really, with all the other faculty there, many, if I start naming, I don't want to leave anybody out, but at least I want to say Dr. Shivaji, Dr. Vijaya, etc., who really instilled that desire to seek knowledge, but also to seek knowledge that is useful in the sense of it's going to be impactful. So I hope I have lived up to their expectations. There's still, as I prepared for this presentation, we've learned a lot, come a long way, but as always, there's still more that we need to do. So thanks again, and I'm going to share my screen and get started so we are respectful of everybody's time. Okay, let's see if this works. Okay, can you all see my screen properly?
Yeah.
Yes,
Okay.
ma'am.
Yes,
Thank
yes,
you.
I can see.
And no other weird things. Thank you very much. So I was invited to talk about trends in maternal nutrition in low middle income countries. And of course, I wasn't told from when. So I chose to start from like today and see, glance backwards. As I do this, I want to also touch a little bit, many of you in this audience, the experts, the students, hopefully know and understand the importance of maternal nutrition during critical periods of growth and development, but I will touch on some key points and then focus most of my presentation on what do we know about trends and progress to date in improving maternal nutrition globally. So some of you may have heard of it about the first 1,000 days. When I was studying, we didn't have this catchy phrase. We all said, oh, we're interested in pregnancy and lactation, early years of life. But this has really been an important, I think, valuable way of thinking of this critical window of growth and opportunity in every life. And starting from conception through the second birthday, interestingly adds to this magical number of 1,000 days. And the reason I'm emphasizing this is, as you see, the mother is so important in this process. I'm not taking away the roles of fathers, grandmothers, other family members, but clearly it's the woman who gets pregnant. The child is, unborn fetus is in her womb. So her health and well-being, including her nutrition, which is a very important part, is central for a successful pregnancy outcome. Once the baby is born, she is still, in most settings, the primary caregiver. We have very early studies showing when the mother dies, the risk of mortality and poor outcomes are extremely high. So she continues nourishing and helping the development of her newborn through breastfeeding as a source
of nutrition, but also a whole range of caregiving, introduction to complementary foods, engaging with the child for growth and development. And we now know that, you know, the critical importance of what happens in these first 1,000 days is not just for short-term consequences in terms of, you know, risk of dying and illness, but it also has very important long-term consequences in terms of returns to schooling, productivity, and the next generation. And this is where I had the privilege to work closely with Dr. Maternal, who continues to be a mentor. When I came to Emory as a postdoctoral fellow, working with the Guatemala study, some of you may have heard, which was one of the earliest maternal nutrition, child nutrition intervention trials that has continued to follow into more than one generation and document. We all sort of knew and believe this is important, but the value of data is extreme, and evidence is important for policymakers when we have competing priorities. And as we've made significant progress in reducing, the risk of dying during early childhood, I still can say when I was working in the field during my dissertation work at CMC Vellore, mortality rates in Tamil Nadu were still in the 3 digits, 100, which everyone thought was. They have come down significantly thanks to, investments in early child, infant health, immunization, safe water, etc. But we still know that brain development is very important. So we really are in an era of, we have succeeded in improving survival, but what about the quality of life? What's the returns to investment? And this begins extremely early, as you see in this slide. Right, that it's not to scale deliberately, but there are many important changes, critical changes that happen during this window that set the stage. We continue using our brains and development continues, higher function continues, but what happens in this critical period is really important for subsequent outcomes. So where does maternal nutrition come here? So this is just a simple diagram that one of my junior colleagues, Melissa Young, and I, who have now been working closely, developed, where we wanted to point out, a lot of work has been done on child-focused interventions, and these are important for improving child health, child outcomes. But you can see in this first 1,000 days, these are not adequate if we do not focus on women, on the mother, especially when she's pregnant, when she's lactating. But even before, and some recent work that I myself have been involved after having done pregnancy trials, that we really need to start earlier. And truly, it is a generational effect, but the importance of adolescent health, the importance of health and nutrition right around the period of conception is increasingly being recognized. So this is why finally there is attention being paid to the importance of maternal nutrition. India has had a history of addressing women's health and nutrition for many, many years, but there is so much more that we need to do. And in the context of helping think through that, we adapted the conceptual framework that was developed for child health outcomes, child mortality. Some of you may have heard or seen what's known as the UNICEF conceptual framework that really lays out when you're trying to improve child health outcomes, that you have to intervene at various levels. And we basically took this and adapted it for, maternal nutrition, and wanted to show how it is important to address many of these factors. At the distal level, there are socioeconomic characteristics, women's empowerment, access to incomes, etc., which influence some of these really critical factors. And we know about the importance of, good health environments and food insecurity. But when you talk about women's nutrition, her status, the age of marriage, issues of gender equality, women's empowerment become very important along with these in determining her conditions, both before she gets pregnant and during pregnancy. And these look very similar, but they have interplaying effects. And if you just focus on pregnancy, yes, we can get something done during that period, assuming she comes early enough into care. There have been studies showing, improving nutrition will improve pregnant, weight gain and therefore reduce the risk of adverse birth outcomes. But we also know there's equal amount of data showing that the status in which she comes in, and these are nutritional indicators, is very critical. They serve as both independent predictors, but also influence the, how much you can benefit from interventions during pregnancy. So this is again why I'm focusing not just on what happens to women during pregnancy, but before they get pregnant. And so I was very fortunate when I started preparing for this talk, and I do teach a course in maternal child nutrition with my colleague Melissa here at Emory. So I want to give her credit for some of this. A recent Lancet series paper by leading people in the field, Cesar Vectora, along with others, including Dr. Parul Christian, Purnima Menon, who's based in India, really examined where are we. The Lancet series first came out in 2013, featuring the importance to invest in maternal child nutrition. And this was really looking at, where are we today? So that came in really handy. And it is on maternal and child nutrition. What's also important is having goals. And for the first time, we had at the global level goals that forced us to think about maternal nutrition. We've always talked about reducing, stunting, which is low height for age, or wasting, and that we've known that for a long time. But the inclusion of indicators and goals such as low birth weight, anemia, breastfeeding, are all very central to addressing maternal nutrition. So that has made it important when you have goals to track these. Are we making progress? It's not that interventions were not done, but it forces us to examine what progress has been made. So what has been made in the area of child nutrition, which is not the focus of my talk, but very intertwined. We have in the last, since 2000, so we're in 2022, so in the last 2 decades, made slow and steady progress. As you can see, these are basic distributions, and in both low-income countries and middle-income countries, we have made some slow progress in shifting these curves towards optimal growth. At the same time, there is the progress for wasting, which is low weight for height and low birth weight, both of which are important risk factors for mortality, morbidity, and subsequent neurological deficits, has remained stagnant, as you can see in this graph. Some progress, but we still, if you just look at just wasting, the numbers have not shifted much. But it's a matter of whether we want to look at the glass half full or half empty. It just does show that the need to focus on some of the causes of wasting, especially in settings such as India, is important. And this comes out extremely clearly when you look at these trajectories. So that is just a cross-sectional. When you look, this is recent data from prospective cohort studies from low middle income countries, showing what are the patterns of linear growth faltering and wasting. And the most important, the 2 points I want to make, that we've made improvements. You see, the dotted line has moved in middle income countries from the red to the blue. Likewise, low income countries certainly are worse off, but they've also moved up. So that's the good news. You see similar patterns, but not as, there's not much movement, right? The middle income countries are better off, but the low income countries have not shifted much in their patterns of wasting. But I also want to point out with respect to the relevance of maternal nutrition, a lot of this happens very early in life, you see, by that time. And in many of these settings, the children are starting off at birth with a disadvantage instead of starting there. And that's reflecting what's happening in utero, and again, the need for focusing on maternal nutrition. So where have we made progress or not made progress? At the global level, in most of this data coming from low middle income countries, we have made improvements in maternal undernutrition using the marker of low BMI. So underweight has declined from 27% to 14.2%. Some movement in short height, which is not something you can change rapidly. It takes generational changes. And more disappointing results, I guess, in the area of anemia, where nearly half women of reproductive age are still anemic. More importantly, this burden is not uniform. We have specific parts of the world where there is a high concentration of underweight, as you can see from this map. Right here in India itself, there is a lot of variation. You can see that the prevalence of maternal undernutrition is higher up in these northern and central states compared to some of the southern states. Similarly, sub-Saharan Africa is very heterogeneous. There are some parts of sub-Saharan Africa, for a variety of reasons, where these rates are much higher compared to the rest of the continent. So the importance of knowing what's happening in subnational regions is really important. At the same time, one of the major concerns is, while we've made progress in reducing underweight, there is also the epidemic of overweight and obesity right at our doorstep. So this is, and I'm sure these numbers have increased. I looked hard, and this is a very nice paper by Lindsay Jacks, where she used the demographic health survey data and examined the annualized change in the prevalence of underweight and overweight in various parts of various low middle income countries. And these are basically sorted by the region and their GDP. So, you have Asia, where China is certainly advanced, followed by these countries, and then going down. And the main purpose of showing this to you is, the differences are not that dramatic between rural and urban. And while many of these countries show reductions, some exceptions, reductions in underweight, almost all of them consistently show increases also in the other side on overweight, really causing us to think carefully as we design interventions to reduce underweight. We do not want to create a new problem, particularly since maternal overweight is also malnutrition and is associated with adverse pregnancy outcomes. So we want women to be in the optimal BMI range. And this is just showing you also that there is a lot of disparities, and these differ by settings. So in a country like Egypt, there's very little difference. Almost the rate of overweight or obesity is extremely high, and it doesn't matter whether you're rich or poor. Whereas some other countries like Ethiopia, among those who are the poorest, there is still some overweight, but it's much lower. Whereas if you go upward on the socioeconomic scale, we are seeing very high rates of overweight and obesity, which have adverse pregnancy outcomes and long-term consequences. In the case of anemia, this is data which shows trends over time, the last 20 years. And you can again see a lot of variation in both in terms of the overall prevalence, with South Asia having very high rates, and also significant improvements in parts of the world like Latin America and East Asia that started off lower, but have also declined. And one of the challenges with anemia is that it is important for pregnancy outcomes, child health outcomes. However, its etiology is quite complex. For many years, we have assumed, and it may be true in many settings, that nearly half of the anemias are iron deficiency. But we have increasing number of studies showing how complex it is and variable. And this may explain in part why focusing only on providing iron during pregnancy is inadequate in addressing this maternal nutrition problem. And of course, we all know that pregnancy is a period when iron requirements increase, and therefore the prevalence of anemia is much, much higher during this critical period. But once again, as I said, I'm quite convinced it's not enough to intervene only during pregnancy. Where women start is really important. And while we need to improve interventions during pregnancy, we need to focus on the preconception status. And again, anemia, again, you see variations. This is a very nice cross-sectional study that looks at variation in the prevalence of anemia in actually about a dozen African countries, where overall you saw the rates are slightly lower than South Asia, but considerable variation by socioeconomic status and by the country you're talking about. So it's really important to understand the local context. At the same time, we do know that there's a high prevalence of several micronutrient deficiencies, some of which I've named here: vitamin B12, D, iodine, zinc, folic acid. We have quite a bit of data showing evidence of vitamin A deficiency. But what's really challenging is we do not have a lot of detailed nationally representative information. A lot of information is coming from small studies, and yet we know it's a problem. I do want to point out there have been some very well-done studies in Nepal and Bangladesh, and recently we also did work in Vietnam, where we see that these do not occur in isolation. If women are deficient in one micronutrient, they're most likely deficient in other micronutrients. And that's really important to take into account of when we're addressing micronutrient deficiency. And so this is sort of the best data. It's scattered, it's not necessarily current, but just gives you an idea of the magnitude with the data that are available for these various micronutrient deficiencies. And you see that in certain areas, it's again, whether the data are available, you have these other nutrient deficiencies. I mentioned night blindness. This is a little easier to measure. You can do surveys, ask women to recall, and we have fairly good data showing that the emergence of night blindness during pregnancy is closely linked to the vitamin A status of the woman before she gets pregnant, and it gets aggravated. And you see again that there are many parts where vitamin A deficiency remains a concern in women of reproductive age. And again, this is, I do not have good data to show what progress has been made, but just gives you a sense of what's out there. And honestly, when you start looking closely at these maps, some of the data are as old as 2000 and some are recent. It's highly variable. So the bottom line is we know micronutrient deficiencies are important, but we really have very little quality data that helps us track progress over time. So that moves me to, maternal dietary intakes. Talked about biomarkers, about anthropometry, but at the end of the day, what are we trying to do? We want sustainable strategies, and it's really important to understand what women are consuming. And honestly, while we're dealing with the undernutrition and anemia, we're also facing overweight and obesity. So examining diet quality is really important. At the same time, food insecurity remains a major concern. A considerable progress was made in the 20th century in increasing food production and making staples available. But in the last 2 decades, food insecurity has actually been increasing in many parts of the world. You can see, especially in Africa, more than half of the people, women, this is not women, but at the household level, have reported experiencing some form of moderate or severe food insecurity, and it's just going up. And I can guarantee with the COVID pandemic, it's not gotten any better. It has probably gotten worse. Asia is slightly better, but it's still not the direction we want to see it. Unfortunately, we do not have data for women per se, but we all know that women probably are affected the most when there is household food insecurity. Many settings, women are the last people to eat. So their access to food probably is even worse, but there is not sufficient data on women's nutritional intakes over time. The good news is we have that with FAO and others more recently developed some simple tools, and this is the minimum dietary diversity tool, which is an adaptation. We all as nutritionists know it would be nice to do 24-hour recalls, how much time it takes to analyze the data. Some countries have variable infrastructure. So this was developed as a simpler tool to just look at diet diversity, started as a tool for examining micronutrient adequacy and has now been modified. But it's really asking women what they ate in the last 24 hours. There's different ways you can do it. You just ask women to list what they ate the previous day or the previous week and then categorize them into these food groups. Or, there's also actual lists which are provided and they have their own set of biases. I was searching for data as what's happened, has diet diversity improved? And I was disappointed that there is very limited data. So this is certainly a data gap. This is cross-sectional data, but at least gives you an idea from a different part of the world where they used the MDDW and found diet diversity ranged women consuming at least 5 of the 10 food groups, which is the indicator that's been recommended, ranged from about 40% to as high as 70%. Dietary patterns differ in different parts of the world. Here, a lot of people did consume, meat products, but their intakes of fresh vegetables and fruits and nuts were low. But what is noteworthy is this study and many others have also demonstrated the value of using the diet diversity score in relation to the risk of anemia and the risk of poor birth outcomes. And as you might guess, these are easier and cheaper to collect and track progress. I was at the same time pleasantly surprised to find useful data from India. And this is an audience from India, so I figured I would highlight where we do have data on changes over time. This is actually a colleague and collaborator of mine from Vietnam who also works with IFPRI and is in India. And they use the NFHS data to look at adequacy of dietary intakes in pregnant women, comparing 2006 to 2016. And you can see, unfortunately, that we haven't made progress in certain areas. This is probably not new to many of you. We know this is happening overall. The intake of pulses have gone down, vegetables, while we are seeing increased consumption of the unhealthy foods. So clearly, there is work to do in this area. These are not quantitative estimates. This paper, if you're interested, I'm happy to share it with the organizers, does report also macronutrient and macronutrient intakes. But I was looking for, what progress has been made. But more importantly, there is a lot of variation. We all know India is a perfect example of heterogeneity, and this shows the variation in dietary intakes across the country, with the going from the darker colors, which are higher intakes, to the lighter colors. So clearly, we're happy to see lighter colors for the unhealthy foods, but still there are parts of the country where these rates are really high. And as we think about interventions, it is really important to understand, what's happening at the local level, whether you go to the state level or even the district level. There's also evidence of considerable variation by socioeconomic status. Especially, we saw the promising news that dairy consumption has improved, but there's still substantial variation by socioeconomic status and other characteristics that they have reported in this paper. So, when we think about interventions and targeting them, these kind of data are very, very useful. So to wrap up, some key points I would like to end with is when we talk about maternal nutrition, there is evidence of limited but uneven progress. We have made some success in reducing underweight and short stature for women of reproductive age, but burden of anemia continues with the high prevalence of micronutrient deficiencies, while at the same time growing obesity and overweight trends are of concern. There are major data gaps. I didn't get into it. We still have limitations in tracking birth weight and gestational weight gain. These are really important measures that combine both maternal and child nutrition. They tend to still be in small area studies. The availability and quality of data on both biomarkers of micronutrient deficiencies and dietary intakes is variable and some often not representative. And really the call is for having, and this has been made by the Victoria et al. As well, that we need regular and timely data collection for monitoring progress. And I would like to finally say the need for continued emphasis on the first 1,000 days by investing in maternal nutrition is very much needed. If we're looking at interventions to reduce low birth weights, wasting, the linear growth retardation that happens early in life, we have to focus on maternal nutrition both before and during pregnancies. We may need to have targeted action in areas where underweight and food insecurity is extremely high. And we can never forget to keep in mind the long-term consequences with the epidemic of non-communicable diseases in many low middle income countries. They are not conditions of the rich, but affect the global burden of disease. So thank you very much for your attention, and I'm happy to take questions at this point.
Thank you, Dr. Usha. It was an excellent talk. And although there is so much information relating to this, but I think you're emphasizing on the preconception nutrition and also the first investing in good nutrition during the first 1,000 days. It is so important. I think we keep reinforcing this message again and again, and I'm sure we will come up with some strategies to reduce underweight, stunting, and other energy deficiencies in the children. And I hope in the next decade, we'll definitely be able to achieve this target. Thank you so much. It was a wonderful talk. So I just have a query. Have you got any data on vitamin D in from the micronutrient deficiencies that you had shown that graph? I think the highlight was on vitamin D was deficient in almost all the countries.
Right.
So prevalence of vitamin D.
Part of this is when you start looking for these, you find them, right? So definitely vitamin D deficiency, we always thought, oh, tropical countries, it's fine, they have sunlight, but there certainly is evidence of vitamin D deficiency. And I didn't get into it. I strongly believe that, we find several nutrient deficiencies for a variety of reasons. We've done a lot of work showing the benefit. If you had to do interventions, you need multi-nutrient deficiencies. And whether it is through providing, multiple micronutrient supplements in a targeted way, or at the same time focusing on diet quality and other relevant interventions. So again, you can see the importance of dairy for countries like India. And it's not that dairy is not available, but do women consume it is the question.
Thank you so much. There are some questions.
Sure.
Everyone has commended the presentation, and one question is: would like to have your inputs on how you assess micronutrient deficiency in community settings. What is the major focus on while dealing with hidden hunger? This is from Dimple.
Yes, so at community level settings, as we all know, doing biomarkers is easier said than done. And that's where I'm feeling quite encouraged by the use of tools like the MDDW. I myself have used these in Bihar and India. They're fairly easy and they serve as a good marker of risk. Obviously, you don't use it for individual targeting, but it certainly gives you a good idea of the extent of the problem and also what kind of interventions then you can develop. whether they're food-based, whether they are food insecurity issues, etc. So that's, I think, the way to go. And in fact, we have some students who are working on looking at the value of this even for adolescent other populations. As you said, because of preconception, can we use this for adolescent girls and not just women of reproductive age? I hope that's helpful.
There's another question by Dr. Rama on what policy measures have proved successful in reducing undernutrition, and where do you think the lacuna is in addressing anemia?
So undernutrition in women, I would love to know the question. Is it for women or children? I'm assuming it's for women. Yeah. So with women, I think a big part is, overall socioeconomic development improvements. There's no question about that. There's some very nice papers, recent papers showing even, investing in programs like the school lunch program, right? In our own home, I still consider Tamil Nadu my home state, have had, long-term effects in keeping girls in school, in addressing their nutritional needs, but also, reducing, increasing the age at first pregnancy, family size, all of these collectively have helped improve the nutritional status of women. You do not have, in many parts, it's highly correlated, women's undernutrition is highly correlated to their fertility patterns and age at pregnancy. So I think this is where, I'm a nutritionist, but I strongly advocate for having these other interventions. We have to work with people in reproductive health. We have to work with people in the food sector. So I think these have contributed to these reductions. At the same time, something like anemia is very multifactorial. And I think having a single nutrient focus when it's not entirely clear that that is the only cause is one of the challenges. I can definitely speak about India because that's where we've had the highest burden and have worked in this area. While we've had programs to provide iron folic acid supplementation, we know that there are many parts where access to supplements is low. People always say women don't consume it, but we did one of our graduate students in collaboration with CARE, did a very nice health systems piece of work showing that they're just not available. So how can you tell women are not consuming? So I think it's a combination of factors of one, coverage and timing, just consuming a few supplements here and there in the last trimester of pregnancy, in my opinion, is way too late. So you need to improve iron stores when it's iron deficiency much earlier. And so we need to do some long-term tracking, but also understand anemia is a biomarker of various things. There are some parts and works being done showing the role of hemoglobinopathies. So the responsiveness of having right interventions. So it's complex, but I think having a multi-pronged strategy and you saw the differentials across different groups. So clearly there is room to move the needle on that.
Thank you so much. Yeah. You were talking about diet diversity, and is it like 24-hour recall can cover, will it give the sufficient data when we are talking about?
Yeah, I mean, a detailed 24-hour recall can be used to generate diet diversity scores, but the detailed 24-hour recall takes much more time, right? When you're wanting to ask about how much women consume, you need right measures, and then how they are analyzed. So definitely, I mean, that's where it's evolved from. But going back to the earlier question in community settings or for tracking progress, a simpler tool. So the MDDW is a 24-hour recall, but it's just a simple one. It doesn't get into the details of how much. It's just even finding out if women even had these foods in their diet in the past day, 24 or 7 day. And people have done this and they found that at a population level, it works fairly well when you have, settings where 50-60% of women are just taking 3 food groups, grains, pulses and, what is that, katrika vendakai, and that's it. You know that diet diversity is extremely low, the other vegetables.
Thank you. Thank you so much.
Based on your experience from Vietnam, Guatemala, Mexico, as well as India, what do you think are the greatest challenges with respect to our country, and how different is it from the other countries where you've been, having your collaborators and you're working? Can you throw some light on that?
Sure. I think the place I learned a lot from actually is Vietnam. It's a very, very, it has a lot of similarities and differences. I think one of the key difference is the healthcare system, the health delivery. It's not fancy, but given the way they function, they have really ensure that access to care is universal. Women, whether it's their family planning service, whether it is their prenatal care, all the way to delivery, the coverage is really good. Quite honestly, their diets are not that great. There is poverty in the rural areas. But one area where, from a women's nutrition perspective, is that family size, the age at first pregnancy is much later. They are also Asian, so as soon as they get married, they want to have that first child. That's true, I think, in many settings, but they've been able to move that age, and then they truly delay that second pregnancy. It is very striking when you look at interpregnancy interval, which allows, I guess, from the nutrition perspective, the health perspective, for the woman, for her health to recover, she's able to focus on the child and then have the next. So this is again why I'm saying differences in some of these, reproductive health factors are important. I mean, their prevalence of low birth weight is 5-6%, even better than some parts in the US. So health disparities, health systems, and ownership is important. When I started working in Vietnam to do a multiple micronutrient trial, we said, okay, everyone's going to get iron folic acid, the government must be distributing it. And we were surprised. We went there and they said, we don't distribute it. We encourage people to consume it. It's available cheaply. So there is a strong emphasis on behavior change. And that's easier said than done in different settings. With Guatemala and Mexico, actually, there are a lot of similarities actually to India. They're just at a different. They've made improvements, but the rates of stunting and maternal undernutrition are quite high in Guatemala, and some of it is related to conflict. Again, there's this underlying factors, I think, which are important, and we see that in India, right? We don't have to go outside the country to look at the variability that is there. And so that's the reason why I shared that conceptual framework, that one needs to understand the more distal causes while we're working on the immediate ones, and be able to have interventions layered. I hope that helps.
Thank you so much. That's really, because even with this COVID, Vietnam seems to be doing much better.
Not right now is what my Vietnamese.
No, but earlier they were. At least.
Yeah. I can tell you this much: they listen.
Okay.
Getting people to listen, or even in the US, is very different. So there's some underlying how countries are structured, right? I mean, the governance is different, and people comply, but it's changing there too in the urban settings, etc.
Thank you.
Thank you so much, Dr. Usha. It's really wonderful to have listened to you, and at this time of the day for you, and very.
I'm a morning person, so this works fine. I just want to wake up 3 o'clock.
It's really, we are extremely grateful to you for having accepted our invitation to be here with us today.
Again, I wish I could have joined earlier and listened to the student stuff, but I'll catch up probably with the proceedings. So again,
it's there in the YouTube link, so you can listen to it whenever you get time. Thank you so much.
Thank you. Thank you very much. Okay, you all have a good rest of the evening. Goodbye.
Thank you so much. Thank you. Have a good day. Thank you so much.
Bye-bye.
So we have now come to the end of today's sessions and request the audience to kindly log in again tomorrow at 2:20 p.m. For another round of lectures by eminent speakers. I now invite Dr. Menaka to propose the vote of thanks.
Thank you, ma'am. Good evening to one and all. On behalf of the Nutrition Society of India, Chennai chapter, I deem it a great honor and privilege to propose a vote of thanks for the two-day virtual international conference on advances and challenges in maternal and infant nutrition. My heart fills with a lot of gratitude and respect to Mr. Dinesh Kumar, Vice President, Nutrition Society of India, for delivering the presidential address. I thank Dr. Vijaya, Director and Professor, IOG Government Hospital for Women and Children, EGMO, Chennai, for delivering the keynote address. At the outset, I thank the speakers for the day, Dr. Chitranjan Yajnik, Director, Diabetes Unit, Camp Hospital, Pune, and Dr. Usha Ramakrishnan, Chair and Professor of Global Health, Hubbard, Department of Global Health, Rollins School of Public Health, Mori University, for enlightening us with their knowledge and expertise. I express my sincere thanks to Dr. Hemlata, Director, National Institute of Nutrition, for her valuable guidance. A heartfelt special thanks to Dr. Lakshya, National Secretary, NSI, for releasing the book and for all his support, guidance, and mentorship throughout this journey. Thank you, sir. I extend my thanks to the judges of the poster competition, namely Dr. Johanara, former Head, Department of Home Science, JBS College, and Dr. Supriya, Assistant Professor, Department of Clinical Nutrition, Sri Ramchandra Medical College. I thank all the students who actively participated in the poster competition. Finally, I thank all the professors, students, and delegates from various colleges for your participation. My sincere thanks to media, press, and Kalanjan TV for the media support, and Mr. Srinivasan for his technical support. I thank Dr. Sharifa Talha, Dr. Ushantni, and Dr. Ramanarayan, and all the NSA organizing committee members and core committee members for the meticulous planning and execution of this conference. With this, we come to the end of the day one. Dear participants, kindly fill the feedback link for today's attendance, and e-certificates will be given to only those who attend 2 days of the conference. Thank you, one and all.
Sir, thank you so much, sir. Thank you, Menaka.
Thank you, everybody. Thank you, ma'am.
Thank you to everyone.
Thank you. Thank you.
Thank you. Sir.